Okay, the live stream has begun. You're welcome to go ahead and start the meeting.
Thank you. Good morning, everybody. The State Medical Board of Ohio retreat will come to order, please, with the following members present. Dr. Rothermel.
Present.
Dr. Safran.
Present.
Mr. Jackalone.
Present.
Dr. Sohn.
Present.
Dr. Johnson.
Present.
Mr. Ganadakis.
Here.
Ms. Montgomery.
Here.
Dr. Feibel.
Here.
Dr. Bechtel.
Present.
And myself, Michael Schottenstein, here. Thank you. So, Stephanie, if you'd be so kind as to proceed from here.
Sure, great. Well, thank you everyone for being here today. I know this is a big time commitment for everyone. And ideally we would be doing this in person, but we're not there yet. So I understand it's also a long day for everybody to be on Zoom. We have built in some breaks as well as a lunch, and given the presenter schedules, we will likely stick to that schedule pretty strictly. So we will be taking the breaks and having that lunch break built in. I know sometimes our inclination is to sort of just go right through the day and to kind of keep moving. But again, we're going to be sticking to that schedule for the day. So this morning, we're going to start our day with, we have Kelly Long here from OPHP. And then really, I think, the tone of our day is education. So we've spent some time as staff listening to the board over the past few months or a year. I guess I've been here almost a year now. So we've been listening to all of you, the questions that you have at meetings, the feedback that we receive from you in between meetings, and put together an agenda of topics that we think address some of those questions and hopefully provide some context to some of where we want to go for the future. Accordingly, we talk a lot about compliance. We have Kelly here to talk to us about compliance. We have some time carved out to talk about the role of the secretary and supervising member. We will be doing some implicit bias training hosted by DAS, and that presentation has been tailored for us based on the actions that you all take. Very helpful. We'll be talking about summary suspensions, of course, and giving you an update on the FSMB report and having some discussion on some of those FSMB recommendations that were made. So a relatively full day. Again, the style is not easy that we're doing this on Zoom. I really appreciate everybody's willingness to kind of play along from home. I think if you do have a question or need to stop the presentation for some reason for a question, that's okay. We would probably prefer you wait until the presentation comes to a natural break, but you may have questions that arise in between, and that's okay. I would just ask that you maybe raise your hand, and I'll try to be watching for those things if I'm not the one presenting and jump in, or obviously just, maybe state your name and say, I have a question. Could you please hold up there? We don't want the material to go too far if somebody has a question that's relevant at that time. So obviously as the day goes, we'll adjust if we need to. But does anybody have any questions about how we're proceeding with the day or the agenda? Okay, Dr.
Stephanie,
yes.
I'm sorry to interrupt. Are you wanting people to use the chat to ask questions, or when you're saying save the questions for the end, you want them to have a dialogue?
I would prefer the dialogue. It's rather hard to monitor the chats portion of the agenda. If that ends up working out easier, then I think we can try that. But if we could, I'd rather have people just raise their hand and jump in, or again, wait until the end of the presentation or until we come to a natural break in the presentation for questions. And presenters will try to be mindful of stopping every once in a while to say, does anybody have any questions? Okay, Dr. Schottenstein, do you have any words before we get started with Kelly? We're a little bit ahead of schedule.
No, I would just say that for some reason, a lot of the videos that I'm looking at are kind of frozen. I don't myself have a good ability to tell if somebody's raising their hands because the pictures look frozen to me. But so Stephanie, if you can see on your end, if you'd be so kind as to, speak up about that.
Sure. Okay, great. And if anybody does have technical difficulties, just let us know and we'll just have to be nimble and adaptable. All right. Okay, sounds great. Well then, Kelly, I'm going to go ahead and turn it over to you to start our day. Thank you so much for being here. Kelly Long is the executive.
This conference will now be recorded.
Kelly Long is the executive director of OPHP and has a presentation for us, then followed by some dialogue. All right, Kelly, take it away.
Great. Thank you so much. Good morning, everyone. And I think Tessie's gonna give me the screen capabilities. There we go. Okay. You guys will have to let me know. We can confirm that you see.
That looks great, Kelly.
My slides?
Yep, we can see your slides.
Awesome. Okay, well, good morning. Thank you again for having me here this morning. My name is Kelly Long, Executive Director with the Ohio Physicians Health Program. For those of you who are not familiar with OPHP, we currently serve as the monitoring organization for the Medical Board's One Bite program. And we're incredibly honored to serve in this capacity and are looking forward to continue supporting the Medical Board and your licensees in this important role. So when Stephanie and I were talking about this presentation, we really thought it would be helpful to provide a little bit of background about OPHP and then really take a deep dive into the One Bite program. So my goal really is to just increase your overall understanding of the One Bite program and our role as the monitoring organization. I hope this presentation will help improve transparency of our processes and procedures as it relates to the One Bite program, to help further strengthen our relationship and how we can work together, and really to gain an understanding of how OPHP can better serve the Medical Board in this capacity. So, like Stephanie said, I've enjoyed working with her for almost a year and members of the staff, and looking forward just to continuing to do so. I believe strongly that as partners in this role, we're better equipped to not only improve the health and well-being of Ohio's healthcare professionals, but we're also better able to protect patient safety as well. So before we begin, I should preface this with I am not a clinician, so I will do my best to answer any and all questions that you might have, but I'll be focusing mainly on just the processes and procedures and not necessarily the clinical components of the program. Some of it's going to be quite a bit of information. Some of it's going to be quite technical. So I have carved out a bit of time at the end to really dive into any questions or comments or areas that you'd like to go through further. So, oh no. There we go. Okay, so with that, let's just get started. So as I mentioned, the overview, we're just going to do a quick history of OPHP and then take a look at the key components of the One Bite program. So that will include evaluation, treatment, continuing care, understanding a little bit more about treatment providers, the monitoring criteria and compliance for the One Bite program, reporting information. We're going to specifically talk about relapses. We'll do a snapshot of the first year of the One Bite program's data, and then just a general lessons learned and considerations after the first year. And then I'll close my presentation by addressing some of the challenges and the ways the pandemic has impacted the One Bite program and its practitioners. So the Ohio Physicians Health Program is a nonprofit organization. Our mission is to facilitate the health and wellness of healthcare professionals in order to enhance patient care and safety. And I'll just make note that it's important to understand that we facilitate treatment. We're not necessarily the people who are actually providing the treatment. So we really started in the early 70s. There was a national call to action by the American Medical Association, coupled with the Federation of State Medical Boards. And the call to action requested state medical associations to create a way to intervene on physicians who were struggling with mental health disorders, addiction, or other conditions impacting their health. And this national call to action followed shortly after the American Medical Association identified addiction as a disease. So Ohio was one of the first states to respond. And there were several medical associations that started putting things in place. But in around 1975, they sort of all came together for the creation of what was then called the Physicians Effectiveness Committee. And it was a subcommittee established through the Ohio State Medical Association. And in those early days, the committees was just primarily physician volunteers. And the way they operated is the committee would become aware of a colleague that was struggling with whatever the issue was, and they would contact the physician in that nearest geographic area who was a volunteer, and they would intervene on the practitioner and encourage them to go to treatment. So over time, the Physician Effectiveness Committee members identified the need to obtain qualified, trained professionals who are used to working with individuals with mental health and substance use disorders. So following this push for full-time staff, the committee became a 501c3 nonprofit organization in 1995 and was called the Ohio Physician Effectiveness Program. We were known as OPEP. Many people still reference us today as OPEP. But in 2001, we changed our name to the Ohio Physicians Health Program. So as a nonprofit, we are governed by a board of trustees, and we now have a staff that is predominantly clinical professionals. We're headquartered in Columbus, but serve the entire state. And prior to the pandemic, there was a lot of travel throughout the state. And now, like you all, I'm sure we've become experts at Zoom. And our goal really is to just provide a safe environment for healthcare professionals to get services that will improve their health and well-being. And we believe as an organization that healthy practitioners provide better quality care. So since I'm talking to you all as board members, I thought it would be helpful to share a little bit of information about OPHP's board. So our bylaws require that over 50% of the board be made up of physicians, but we also have consumer members, a counselor, representatives from other healthcare professionals that OPHP works with, such as a veterinarian, an optometrist, and a chiropractor. So as you can see listed here, sorry, I'm on 2 slides, I'm looking back and forth. Our board represents many healthcare systems from Ohio Health to University Hospitals Cleveland, Ohio State, Mercy Bon Secours, Kettering Health Network, and others. We have a couple of physicians affiliated with medical schools. I think we've got Ohio State, OSU, and Case Western, and then some that work for insurance companies. So our current board chair is Dr. Christina De Los Reyes. She's a physician from University Hospitals in Cleveland and is an addiction psychiatrist. So it is important to know that while some of our board members do have training in addiction medicine and psychiatry, we also have a variety of other specialties. So it's not just singularly addiction medicine. Our board members are family medicine physicians, OB-GYNs, surgeons, we've got sports medicine, emergency medicine, occupational medicine, and some others. So on to our staff. So as I mentioned earlier, there was this push for highly trained professional clinical staff. So we are a predominantly clinical staff. Our leadership includes a psychiatrist serving as our wellness director, an addiction psychiatrist serving as our medical director, and our clinical director is a master's level clinical counselor, an independent chemical dependency counselor. And then they sort of lead our case manager team, which does a little bit more of the day-to-day interactions. In that case manager team are chemical dependency counselors and a social worker. And then they have a team that supports them with a little bit more of the administrative responsibilities, but they're also all chemical dependency counselor assistants. So if someone calls our office, ideally they're going to be able to talk to someone who has specialized training in chemical dependency, mental health. Some a little bit biased, but I think our team is really great professionals who are extremely passionate about what we do. So to help better explain the scope of OPHP services, I thought it might be helpful to know just a little bit about who OPHP serves. So we obviously serve as the monitoring organization, as for the One Bite program for the medical board, but we actually provide services to 4 other healthcare regulatory boards. We currently work with the Ohio State Dental Board, the Ohio Veterinary Medical Licensing Board, Ohio State Chiropractic Board, and the Ohio Vision Professionals Board, and then all of their licensees. So we do kind of provide as requested services for some additional healthcare boards, like the EMS board. We work a lot with EMTs, firefighters, and some of these boards, we'll talk a little bit about it in the next slide. We do a kind of a dual role, but we also are able to do comprehensive behavioral health or substance use disorder evaluations. And sometimes we do these for the board to help them determine sort of what their next steps are in their processes. So we really break down our services into 3 different programs. We have what we call a confidential resource, educational outreach programs, and then what people mostly know us for is the monitoring and advocacy program. So our confidential resource is just best described as the ability for any practitioner, any hospital, employer, etc., to contact OPHP and ask for information. So they can do this without telling us who they are. They can tell us who they are, but it can be anything from asking for evaluation information for a disruptive behavior situation in a hospital, or to a physician who's simply just looking for a counselor or a therapist in their area. So I'm going to hop down and talk about our education and outreach programs. It's pretty self-explanatory. So our clinical team, now expertly through Zoom, will do presentations to hospitals, associations, medical groups on addiction, mental health, stress, burnout, and then we do presentations on the One Bite program. So as part of the One Bite program rules, OPHP as the monitoring organization is required to provide education on the One Bite program to Ohio's healthcare professionals and treatment centers. And then our third and most well-known program is what we call monitoring and advocacy. And in this program, we provide comprehensive monitoring services for individuals who have completed treatment. So again, important that we are not the ones that are providing the direct care. But this is most notably for individuals with substance use disorders. So our monitoring is delivered through what we call a monitoring agreement, and we'll cover that in sort of some of the upcoming slides about what's included in a standard monitoring agreement for, we'll do specifically the One Bite program. So I wanted to take just a quick moment. I know this has come up in some of the conversations about what OPHP means when we say the word advocacy as part of this MUST program. So While most of our program participants are being monitored confidentially from the licensing board, that doesn't necessarily mean they're confidential from their employers. Credentialing, if there's a DUI, it's not confidential from the judges and the court system. So to support our participants, we write letters of compliance. We reference that as like earned advocacy. And so these letters go to third parties. They can also be done in a hearing or a testimony. And it really is just explaining the practitioner's involvement in our program, the requirements in their agreement, and then ultimately whether or not they've been compliant. So this process we like to think is pretty similar to what the medical board's compliance team does when they're preparing letters on behalf of a probationer who's under a consent agreement or a board order. For example, a probationer might be seeking to get their Medicaid or Medicare provider privileges reinstated and need to have confirmations sent to those departments to confirm that they're in compliance with their agreement. So it's a pretty similar process. I do understand how the language can be a bit confusing without context. So I just want to make sure people know, like, we're not a membership organization. We are a direct service organization that specializes in providing support for mental health and substance use disorders. So as I mentioned earlier, we do work with 4 other healthcare regulatory boards in addition to the medical board. And the services are similar and different, but I've tried to outline them in 2 separate columns. So with the other healthcare regulatory boards that we work with, they typically honor some type of one bite, some type of confidential program in lieu of disciplinary action in their own way. It might not work exactly like the one bite program, but it's some variation of that. And so the processes work pretty similar. They can be confidentially monitored without the board's involvement, so long as they maintain compliance with their agreements. Some boards require that we complete assessments. I think I mentioned that earlier. And we can do these as sort of a preliminary basis to determine if the board's action should include some part of treatment and monitoring, or if there's not evidence of a mental health or substance use disorders. And then we also help some boards establish, either with them or independently, what would be considered approved treatment providers to work with. And then uniquely, some boards allow us to work with them on like an individual case-by-case basis when there is an instance of a practitioner relapse or a compliance issue, to determine whether or not that practitioner could stay in a confidential monitoring agreement, or if the board's disciplinary process is more appropriate. You know, is somebody following recommendations? Are they highly motivated? You know, or is someone just really kind of digging their heels in and not wanting to do the things that are required? So kind of shifting off into the right column, what's different from our services that we provide to the medical board for the One Bite program is for the other healthcare boards, we do what we call compliance monitoring. And this is monitoring for disciplinary cases related to impairment. So in these cases, we essentially create a monitoring agreement that would include all of the clinical and monitoring requirements of the consent agreement or board order. And then we build out additional clinical components to support that individual. So then as part of that, we can now help the practitioner enter an evaluation if that's a criteria, enter into treatment if that's a criteria, help them coordinate aftercare or continuing care as appropriate. So to assist with sort of that back and forth, we issue quarterly reports to the other healthcare boards on the status of their compliance with the monitoring agreements. And then we typically include all of their toxicology test results as well. So for all 4 other healthcare boards, we really have to work independently to determine what they factor as a reportable item. And so we determine what's the time frame they want us to report the information, and then ultimately how it should be reported. Phone calls, emails, is it they only want to know about relapses, or they want to know, kind of lay out the framework of what information should be provided to them. So I've prepared a little bit of information to highlight just what OPHP participants look like in our monitoring program. It's important to note this is both practitioners who are confidentially being monitored and those who are being monitored for that compliance piece who have disciplinary action. So you can see 56% of our monitoring agreements are with physicians, 13% are with residents and medical students. And then we have sort of blocks, 10% represent dental professionals, about 10% represent veterinarian professionals. Then we have 6% that are sort of other licensed. So you might wonder where our referrals come from or who's contacting our program and for what reason. So in 2019, 64% of our referrals were for practitioners seeking help for substance use disorders. 17% are looking for educational information. 7% are calling about mental health disorders. 3% are calling about behavioral issues. So behavioral issues for us are most commonly related to what's sometimes called a disruptive physician or a distressed physician, a physician maybe not playing well with the nurses on staff or having some difficulties working with other colleagues. And then 9% you sort of clump as others, which don't fit into any of the other categories, but are most commonly like community resources. Somebody's looking for a counselor, psychiatrist, attorney, a CME course, that type of thing. So our referrals come from kind of everywhere. In 2019, 26% of our referrals came from the individual practitioners themselves, which is a number that we are really proud of. We've got 23% coming from colleagues, hospitals, employers, followed by treatment providers, licensing boards. We get referrals from other healthcare professionals, attorneys, families, and then anyone who doesn't fit in those categories kind of gets lumped into an other. But just to touch back on the self-referrals, so we really think that that being the most common referral source is really reflective of a program where people are starting to become comfortable in asking for help. And our hope is that as we continue to implement and improve the One Bite program, ideally we'd love to see that number continue to increase where people are reaching out. So now that we've gone over a little bit of information about who's accessing our services, who's in the monitoring program, I wanted to share with you a little bit about OPHP's success rate. So of the participants completing monitoring agreements specifically for a substance use disorder, and again, this is a collective number of all the practitioners that we serve, about 92% complete their agreement with ever having a relapse. This is a statistic we're really proud of, because if you were to compare this to the general population, and if you were to reword it just to make the numbers fit, so about 8% of our participants relapse. In the general population, in the first year, you're looking between a 70 and 80% relapse rate. And then second years and on, it sort of goes down successively, and it really doesn't drop down comparable to these numbers until about the 5-year marker. So it's definitely, I guess, evidence that what we do works. I know the compliance team at the board, what's being done works. And nationally, PHPs have pretty comparable rates to what you're seeing here. I think sort of the national averages start around the 78% and then go up. So now that we've talked a little bit about OPHP, I'd like to move on and talk specifically about the One Bite program. I didn't know if this would be a good place if there's any questions, or if I can just take a deep dive in and keep on going. Yes.
Ms. Montgomery.
Yes. I guess the elephant in the room is, how do you define one bite? The 92% is thank you so much, by the way. I appreciate all the information. 92% is a pretty, is obviously a significant claim to fame. It seems a little high, to be honest with you. So I guess I'm going to have to ask you how you define relapse.
Yeah, so I think we'll get into that specifically in the One Bite program. So, but when we're doing that statistic, it's really any incidence of a return to use. So we don't typically determine a relapse. We would work directly with the practitioner and the treatment professionals that are approved for whatever type of licensee that we're working with. And so really any deemed clinical or self-identified relapse would be counted in that statistic.
Because if you were dealing with substance abuse other than alcohol, when you're looking at an opiate, it's a little hard to believe that you only have 8% relapse. And I'm not calling your integrity into question. That's why I'm asking the question, how you're defining relapse.
Sure, I understand. I think really it's sort of a couple of component of, the people that are in this statistic have access to a level of treatment that the general population doesn't. They have access to resources and people holding them accountable and supporting them that I think the general population doesn't. And so, yeah, I think we'll talk about it a little bit later. I'm also happy to bring some of our clinical folks to the table to have that discussion as well.
Thank you.
The other thing is, remember the population that we're dealing with. These are healthcare professionals, right? So it's also not the general population. The likelihood is that the same qualities that allowed one to pursue and complete their healthcare education and training also are brought to bear in terms of their working their program.
Yeah, great. Thank you.
Yeah, Bob.
Sorry, I had to take myself off the mute. Again, thank you, Kelly, for the presentation. Quick question, just in your funding, how do you fund your organization? Is that through, participants? I'm just curious.
That's a great question. So our funding is predominantly grants and donations. And then a portion of our revenue is generated through participant fees. So when a practitioner enrolls in monitoring services, they pay a monthly fee for those services as well. That makes up, I believe, about 25% of our operating revenue, but about 60% is grants and donations.
That's pretty significant. Who can I ask you? Who grants and donations is like the Ohio State Medical Association? Who is your primary donor? I would assume it's got to be. I don't see you guys picking $5 from every physician in the state, but I may be wrong.
Yeah, so we have a couple of foundation grants that provide us with substantial funding, and then we get a large portion from hospitals and medical staffs at hospitals. And then some organizations, like you mentioned, provide donations, and then a little smaller of a portion are from individual donations.
Okay. Thank you.
Thank you.
Oh, Dr. Sohn.
Yes, thank you. Good morning. Kelly, great presentation. I appreciate all the advocacy that Ohio PHP does for physicians. And I think it's a really great service. And I've certainly heard anecdotes from physicians who are grateful for your help and support. But therein lies my question for you. And what would you say about someone who might be critical of Ohio PHP in the fact that how do you maintain objectivity when you're dealing with physicians? Or specifically, how do you balance the needs and goals of physicians with the needs of protecting the public? And the reason why I asked that is Ohio PHP came and did a presentation at my hospital some years ago. And it seemed to me from that presentation that was more of almost like an advocacy group for physicians who are impaired, which is great. Obviously, they need that. But for my role at the medical board, that makes me wonder who's advocating for the public, right? Or the patient who may, have to be cared by this physician. So can you answer that question on how you maintain objectivity and balance advocacy of physician with balancing the needs of the public?
Sure. So that's a great question, actually. And I definitely try to hint on some of that when we're talking about earned advocacy. So I don't know that we're necessarily positioning ourselves as advocating on behalf of a group of practitioners. It's really on an individual basis, and it's really about earned advocacy. So I think what we've established is conditions in our monitoring contracts that we believe support a practitioner's ability to continue practicing. And we're very diligent about overseeing those terms, making sure the practitioners are compliant. And we'll sort of tie into, I think this may answer some of your questions as we dive into the One Bite program, because we're going to talk specifically about what our staff does with the individual practitioner. And it's not just about making sure they're compliant, but because we have clinical staff, we're constantly evaluating sort of the overarching well-being of those individual practitioners, identifying if there are risks, are there things that we should be doing. And so I hope that we're not perceiving ourselves as acting as a collective. I mean, we do believe in physicians having access and healthcare professionals receiving support and treatment for an illness that can be treated and managed successfully. Like I mentioned, we believe that healthy practitioners provide better care, but we are very mindful and take very seriously our role of making sure there is a safeguard in place, and that practitioners are not being held accountable for the conditions that they sort of adhered to in that contract. So I don't know if that answers your questions, but I do think we will we'll hit a little bit more into that as we progress through the One Bite program.
Well, let me just ask a quick follow-up, just a little bit more direct, I suppose. Do you have like a third party or independent peer review that reviews your work to make sure that you are compliant? Are there other groups that are independent that audit your work is specifically my question.
So, I mean, we're governed by a board of directors that has the ability to step in and review our work, similarly to the board's process. Although we don't have something in place right now, we are working with the Federation of State Physician Health Programs. They're getting to roll out sort of an audit process that we will be taking part in those regularly.
And sorry to keep harping on this, but are those board members independent, number one? And number two, do they have a formal process where they routinely audit your work, or is it up to their discretion?
So it would be up to their discretion. And I'm not sure if you mean independent.
Non-affiliated with
employees of the organization. So They are volunteer just in their capacity.
Thank you. That's helpful.
Thank you. So if there's no other questions, I'd love to kind of head into the next part of the presentation, which is specifically about the One Bite program. So as a reminder, the One Bite program allows an eligible licensee of the medical board who's impaired due to a substance use disorder to avoid formal disciplinary action when certain conditions exist. And OPHP is approved to serve as the monitoring organization to facilitate this program. So I thought it would be necessary before we kind of go into the specifics to really just address the fact that the very nature of this program can cause a certain amount of unknown or unease. And we understand the concerns about not knowing about a practitioner. So I'm hoping that by going through the program more fully, and about our program and scope of services, you'll feel more confident in the One Bite program and what it provides to the medical community. So confidentiality is an important component of this, and there are lots of barriers to why professionals don't ask for help. It can be from professional isolation to fear of losing jobs or families, or fear of losing a license. So I think the spirit of the confidential One Bite program is to create that safe space for people to get help. And I think the utopian long-term goal would be that practitioners are asking for help sooner, because as with any other disease, if it's detected earlier, the earlier it can be treated and the better the outcomes. But in order to promote confidentiality, there are rules and statutes that prohibit OPHP from disclosing participant information unless they're determined to be ineligible for the program. The practitioner requests the disclosure if they're unwilling or unable to comply with the conditions, which could include evaluation, treatment, and monitoring. If the practitioner presents themselves as an imminent danger to the public or themselves because of their impairments, and if the practitioner has relapsed or if their impairment has not been substantially alleviated. So as defined in the One Bite program laws and rules, the practitioners entering the One Bite program have to meet 3 eligibility criteria. So OPHP oversees making the determination, and we work directly with the treatment providers for some of this information. But it's really just, are they impaired? i.e., do they have a substance use disorder? Have they not previously participated in the program? And unless the board refers them to us, they've not previously been sanctioned by the board for an impairment-related incident. So understanding the eligibility, I've sort of broken down the One Bite program into 5 separate requirements. And we'll go in depth requirement by requirement to help sort of understand the processes. So just as a quick overview, the requirements are to get an evaluation, to complete treatment, to suspend practice for a minimum of 30 days, complete a minimum of 6 months of continuing care, and complete a 5-year monitoring agreement. So just starting in with that first requirement is seeking an evaluation. So a practitioner has to complete an evaluation at an approved One Bite program treatment provider. So the process really is that The practitioner will do an intake with our clinical director. They'll be pre-screened for evaluation criteria, collecting information about the individual, what's going on in the environment or the incident that occurred. In the background, we'll be confirming the licensee's status to make sure that it's active with no prior action by a board for impairments. Our team will be explaining the evaluation process to the practitioner, and then we'll ultimately provide them with a list of approved providers where they can complete this evaluation. So when this is all happening, we're typically getting releases of information so we can get updates from the treatment providers as the evaluation is ongoing. And then typically at the conclusion of the evaluation, prior to getting a written detail, we're getting some sort of verbal feedback about what the findings were of that assessment. So it's worth noting these evaluations are the same criteria that practitioners have to abide by when they're ordered to an evaluation by the board. So I think we know them as 72-hour residential or inpatient evaluations. So they're pretty significant, pretty time-consuming, and the average cost is between $4,000 and $10,000 to have this done. So if a practitioner completes this evaluation and there is no diagnosis of a substance use disorder made, for us, that the One Bite program is not applicable to them. They're not, or we reference it as they're not eligible. That's actually the first criteria of eligibility for the One Bite program. So our process is really that we would collect all the documentation from the treatment provider and issue a letter back to the practitioners stating what the One Bite program is, that they've completed this evaluation, there was no diagnosis of a substance use disorder found, and that their case with us is closed. Want us to do that. So if the practitioner completes the assessment, let me back it up one slide. Yeah, so if the practitioner completes the assessment and there is a diagnosis and recommendation for treatment, then it sort of kicks into requirement number 2, which is to complete treatment as recommended. So we will help the practitioner enter into an approved treatment provider if they don't want to stay where they completed the assessment. We help oversee that treatment plans are being done based on individual recommendations. And this can be a multitude or a variety of levels of care. We'll talk about that in just a second. And then our clinical team gets pretty much weekly updates when someone is in treatment about their progress and how they're doing. And then so we know pretty well in advance when an anticipated discharge date is. And so we try to establish an appointment to set up a monitoring agreement as close to their discharge date as possible. So that way there's no time in between leaving treatment and beginning those monitoring terms. So treatment as recommended is a relatively new term. Historically, treatment has been done through a minimum 28-day stay in a residential treatment center. And so this still holds true for practitioners that are coming through the board's disciplinary process for impairment. But for the One Bite program participants, they have to complete treatment as recommended. So that can be residential, but it also may include other types of treatment. So in the prior One Bite, so the 1987 version, the requirement was a minimum of 28 days of residential treatment. So we've seen the treatment centers that are slowly starting to incorporate different types of treatment as a part of this process. But again, just kind of worth noting, the treatment itself is being done at really reputable, great facilities. But if you're paying out of pocket, it could range anywhere from $18,000 to $50,000 for a 30-day program. So I thought we'd do a quick little sidebar about treatment. I know I did the preface that I'm not a clinician, but my clinical team helped me with these slides, and they think I'm semi-equipped to review this. So I will apologize for any of the physicians on here, that this will be a very elementary overview of treatment. So treatment as recommended is determined based on 3 components. You have the DSM-5, ASAM criteria, and then there's special considerations for what we call a safety-sensitive profession. So this could be a physician, an airline pilot, anyone who really has direct capability of harming a patient. And so what they're looking at are those criteria and matching the number of symptoms that they meet. And you can have basically 3 types of a substance use disorder. So you can have a mild use disorder, a moderate use disorder, and a severe use disorder. And your treatment should really factor in all of those things. The number of symptoms you have, the type of profession that you're in, and it can lead into what we think of 5 levels of care. These are not actually the clinical terminology, but this is how people reference them so to help understand. So the first one you have is inpatient treatment. It's a medically managed care. It's what we think of when we think of detoxification. So you have round-the-clock nurses, round-the-clock medical care access. It's not just detox, but it's what we most commonly think of when we think of inpatient. So the next level of care is residential. So residential treatment is traditionally where the individual is living on site, living on the campus where the treatment is being completed. Again, it could be inpatient, but in a residential setting, there's typically not that round-the-clock care that you would see in an inpatient or detox level of care. So then you move on to what's called partial hospitalization, and not at all like what it sounds. So this is an environment where individuals live off campus. Sometimes it can be in treatment center owned apartments. And then the individuals are shuttled in or commuting in for all day comprehensive treatment. They're just not living on the campus. So the 4th treatment level is called intensive outpatient treatment. And this is a little bit of a step down from partial hospitalization. This is often where they'll be living at home and commuting into the treatment center for a multi-day, multi-hour continuation of treatment, but it's not as all day as that partial hospitalization care. And then we think of those top 4 as like their acute care or their primary care. And then the last piece is considered outpatient or continuing care, or what's most known as aftercare. And that's essentially like if you think of like a regular checkup. The individual is going back to the treatment center once a week for about an hour, just to see how things are going, kind of putting the eyes and ears on that individual. So now that we have kind of covered the basic levels of treatment, I just really want to kind of put into context the treatment centers. So the treatment centers that we have in-state, out-of-state are providing some variation of these levels of care. And there is an approval process through the board for a treatment provider to become approved for the One Bite program to do treatments and the One Bite program to do continuing care. And in order to be eligible to be a One Bite program provider, you have to first be approved as a medical board treatment provider. And one of the biggest separations between the two is that in order to be a One Bite program treatment provider, you have to offer what we consider professionals programming, or programming specific to an individual who holds a professional license and understanding what it means to have that license and be going through treatment for a substance use disorder, understanding there's going to be accountability, monitoring conditions, and what the board statutes and rules are related to an impaired practitioner. And one of the other kind of differences between the two types of approval is, in order to be a medical or a one-bite program provider, the treatment has to be provided by master's level clinicians. Specifically, that's really targeted at continuing care. In the past, sometimes it could have been done by a volunteer or a lower level clinician. And we thought it was really important to have someone who knows what they're doing and has significant experience facilitating those groups. So in-state, we have about the same number as out-of-state. Most of our out-of-state providers are what you think of when you think of a true professionals program. So you're going to be in treatment with a number of like professionals, physicians, attorneys, pilots, that type of thing, who have sort of all the same level of stakes going through treatment. So our out-of-state providers are Bradford, Positive Sobriety Institute in Chicago, Caron, Cornerstone of Recovery, Lakeview, and MAR. And I think that if you pulled the PHPs or medical boards sort of across the nation, I think these are some of the top programs that offer professionals programs. And then in-state, we have sort of the usual suspects. These are folks that have provided treatment for a long time to professionals in the state of Ohio, but maybe don't necessarily have a true professionals program, but are used to working with professionals and are likely going to be in session with others. So you've got the Cleveland Clinic, Glen Bay, Parkside, Recovery Village, Shepherd Hill, and The Ridge. And you can see I notated some of the in-state providers have specific types of treatment that they can provide. So for all of the one-bite treatment providers, OPHP does like an initial onboarding to make sure they understand all of the requirements, all of the things that they have to do. And we also offer monthly online trainings for all of the treatment centers and their staff, just as a nice little reminder of the one-bite program and their requirements. Okay, so we'll hop back to the requirements for the one-bite program, and we've covered requirement number 1 is that evaluation, requirement number 2 is that treatment, and requirement number 3 is about a minimum time out of practice. So if they receive a substance use disorder, we'll help them get into treatment, and when they begin treatment is when that 30 days begins. So no matter what type of treatment the individual is completing, they have to be out of practice for a minimum of 30 days. And sort of the safeguards in place that are new, so under old one-bite, there weren't return to work requirements. So as part of the new one-bite, there are. So the practitioner has to be deemed fit to practice by the medical director of the treatment center, and then also be deemed fit to practice by the medical director of OPHP. So this is a nice little safeguard to make sure the practitioners are not heading from treatment right back into practice. And our process really is, we don't consider someone even eligible until they've already been cleared by the treatment center, they've started and entered that monitoring agreement, they've already started doing toxicology testing, and we have to have, if not one, multiple negative results before our medical director will clear them to go back to work. So although it states minimum of 30 days, I would say right now we're seeing at the earliest everything going smooth sailing. Typically, you're looking at a 45 to 60 day time frame out of practice. before being eligible to return to work. So sort of heading into, we've covered first three, so the fourth requirement of the One Bite program, and thinking about the levels of treatment that we just talked about. In order to begin continuing care, a practitioner has to have been successfully completed or discharged from their primary care, right? So we have that inpatient, residential, partial hospitalization, and intensive outpatient treatment. Once those are done, or any combination of those, then the practitioner is eligible to begin that continuing care. So this has to be done by an approved provider, and it is, again, that sort of checkup style. It's a once a week, minimum of an hour, facilitated by a master's level clinician, and only once, so they have to finish a minimum of 6 months. And at the 6-month marker, they can be reevaluated to determine whether or not they can complete or whether or not they would benefit from continuing on further with additional continuing care. So OPHP gets sort of standing monthly verbal and written updates from the continuing care providers. So we're pretty well aware of how someone is doing. But at that 6-month marker, we're really comparing notes between the treatment provider and OPHP to make sure, hey, have there been any issues with continuing care? Have there been any issues with compliance, or is everything going okay? Are there any major life obstacles that are coming up? A job change, a divorce, a baby, things like that may be beneficial to have that person continue on for a little while to get them through that life milestone. So once we're sort of in agreement with the treatment provider, it's the same process as the return to work. We get sign off from the treatment center saying they've been deemed complete with this requirement. And then we'll have the practitioner meet with our medical director and just sort of assess everything and how they're doing before we would deem them complete with that requirement. We've seen a little bit of that. I think in the beginning, people weren't really sure what to do. But I think now that the treatment centers are a little bit more comfortable, we've definitely seen instances where that continuing care has been recommended for longer. Again, just sort of cover those major life challenges. So last but not least, the fifth requirement, right? So we've talked about the evaluation, we've talked about treatment, we've talked about the time out of practice and the continuing care. And so the sort of last but not least is just this monitoring agreement. And so just acknowledging that these aren't necessarily successive just because that's how I have them ordered. You would be in monitoring while going to continuing care. But a monitoring agreement is minimum of 5 years. The practitioner is subject to random toxicology testing. They are required to go to and document their recovery support group meetings. And those are sort of the bare bones requirements of the program. And in addition, we're asking them to complete self-evaluation forms. We're asking people to establish what we call a volunteer peer monitor, most often someone they work with that can report back regularly on how they're doing. And then anything that the treatment centers have included outside of those basic requirements. So we have treatment and continuing care, but there may be instances where they're requesting the practitioner to go to individual counseling, begin seeing a psychiatrist, kind of any and everything. And so we build those components into the contract. And so one of the biggest thing that sets us apart from what we think of as traditional monitoring for just compliance. Right? So we have these criteria that we know people have to follow. But in addition to that, every participant in our program gets assigned what we call a case manager. And this case manager, as a clinician, meets with the practitioner regularly throughout their time over the course of those 5 years. And I wanted to just highlight a little bit about what the case managers are doing. So they are, in fact, assessing the compliance to the agreement. Are you checking in every day? Are you doing the testing when you're supposed to? Are you showing up at continuing care when you're supposed to? Looking at those self-evaluation forms, kind of just the standard components. But they're also assessing just kind of their general well-being and recovery status. They're performing brief mental status exams, looking at appearance, behavior, their mood, affect, cognition, thought process, thought concerns, insight, judgment. They're also looking at the overall mental health or physical health of the practitioner and any concerns. They're sort of assessing a relapse risk, where they are in their recovery, and then working with them to address any work or personal concerns. Again, we mentioned sort of life things. Are you getting a new job? Are you having a baby? Are you getting married? Are you getting divorced? Just serving as sort of like an on-call counselor, if you will. And so in addition to that, any practitioner who comes to our program that has a co-occurring mental health disorder, they're assigned a case manager that has a mental health background. So social worker, professional clinical counselor, that type of thing. And then we also provide a level of oversight from our psychiatrist who checks in with those individuals. It's typically monthly, but it can vary depending on where they are in their agreement, just to check in and provide an additional level of accountability and support. So in addition to the case manager's role, our team prepares quarterly status reports. I imagine for some of you, this is a really familiar process, comparable to what the board's compliance team does. And so you're really just taking a look at a 90-day snapshot of how the practitioner is doing, looking at all of their toxicology testing activity. Are they attending the meetings that they're required to go to? And then did we collect all of the reports and review it for continuing care, those self-evaluations, monitor reports, prescribing physician reports, psychiatrist, therapist, you get the idea. And then we're looking at their current prescriptions as well. So to support the case manager's role and to follow up with those quarterly status reports that are prepared, we follow a pretty simple 3-level compliance system. And this system is integrated into our electronic database. So at any time, we can run a list of any of the practitioners in our program that currently have some type of deficiency. That's how we identify it. This is something that when we started the implementation process for the One Bay program, we did share this with the board staff, got feedback. And so I think hopefully I'm going to go over today a little bit of how it works. It can be successive. It also can just be something can be high enough of a risk that it goes directly to a level 3. So what we identify as a level 1 compliance deficiency is occasional missed check-ins or call-ins, an inability to meet the minimum support group attendance requirements, or maybe not attending them the correct way. So we don't allow for what we call stacking of meetings. So if we want someone to go to 3 support group meetings in a week, but they're doing 2 in one day and 1 on another, that would fall under a level 1 because we want them to go on a daily spread out basis. So then it's failure to submit documentation. So if we know they're taking an over-the-counter medication, we request that they fill out basically a daily medication log. Or in general, if they're just missing any of their paperwork for that quarterly status report, self-report, a monitor report, psychiatric report, whatever it might be, So we classify that under level 1, and we typically are following up right away. In certain circumstances, we're giving a person a quarter to demonstrate their compliance, right? So if in a quarter we had that practitioner stacking meetings, we would be monitoring that for the next quarter to ensure that they're complying with the requirement. So if we have unresolved level 1s, they sort of move into a level 2 compliance deficiency. And we further define this as a little bit higher of a risk. It requires a little bit more prompt attention. We typically start getting the clinical director and the medical director involved directly at this stage. And it's, frequent missed call-ins. They didn't do a test when they were selected. If there is low attendance or a deficiency identified in their continuing care requirements, or if we have a positive result due to an over-the-counter medication. Typically in those instances, we know that they're coming. Somebody will tell us. But we usually, for toxicology testing, it's a little bit different. We require that they resolve that in 72 hours. So we know if it's a prescription medication. But for everything else, it will really just depend on what the plan of action is. Again, you're getting the clinical director involved, medical director involved. So if you're looking at frequent missed check-ins, you're probably looking at increasing their testing frequency. If they've missed a toxicology test, you're probably looking at a different panel or a different method of testing to accommodate. And then usually it comes with an increased frequency until someone can demonstrate continued compliance with their agreement. So these are, again, typically we're looking for like a 1 month sort of clean health, and then we'll monitor it. So we'll do kind of a daily oversight for a month, and then we'll monitor that for the next quarter. So in the event there's an unresolved level 2, which doesn't happen very often, is pretty few and far between. Most of the level 3s are sort of standalone items that are either an immediate reporting, an immediate request for someone to stop working, or just sort of requires an all hands on deck type scenario. So the level 3s for us are sort of everybody get involved. It could be, the medical board is investigating that. We've heard they're licensed in another state, and we got a report from that physician's health program that they're not doing what they're supposed to be doing. Any refusal to follow OPHP's recommendations, whether that's testing, going to additional meetings, being reevaluated, extension of their continuing care, those are red flags for us. If there's a termination of a continuing care contract, that's a level 3. And then these are sort of just kind of like reporting things for us. If there's been a dilute specimen that was determined to be deliberate, would be a report for us. And then if there's what we call an undocumented positive, so we have positives based on prescriptions that's not otherwise addressed in a policy. And then any relapse is a level 3. So I wanted to just give an example of how maybe something in a level 3 might not be an immediate report, but there can be some type of resolution. Would be if we got notification that a continuing care contract was terminated and we looked into it, we would want to know who terminated it and why. And is it something as simple as the practitioner told the continuing care provider they're moving, and so then they need to transfer that continuing care to a treatment center closer to their location? So again, these don't happen often, but what we see most frequently as a level 3 is relapsing. And so wanted to just have a slide and talk specifically about what happens when there is a relapse. Sorry, I'm just keeping a quick check on the time. So when we get information about a relapse, either a positive test result or a self-disclosure of a relapse, we're advising the practitioner to stop working immediately. And then we're assisting them and re-entering treatment at a residential level of care. So we would know that if they're losing their eligibility to be in the One Bite program, that treatment requirement is now a residential environment. So even if someone relapses, they should be going right back to a residential level of care.
Excuse me, Kelly.
Yeah,
Ms.
sorry.
Montgomery, did you have a question?
Well, I was just, when you get it, you're getting, I'm sorry to interrupt, but you're getting into now telling us what what you think would be defined as a relapse. But I'm looking at, as you progress from level 1, level 2, level 3, a lot of this appears to be sort of subjective. And again, I am very personally impressed with your compliance issues. But obviously, as you progress from level 1 through level 3, a lot of us might disagree with what you as determine as a relapse versus that we should know about, versus when you define it as a level 3, all hands on deck, as you said. Now, I mean, it's obvious, if you've got an incident or a self-report, but the other level 1s and 2s can be fairly nuanced. And so your monitoring program is very impressive, but obviously we as a board are concerned as to the safety, as reflecting what Dr. Soin commented on earlier. So I wonder how you can address that, because you said, and your quote was, they want to resolve within 72 hours, for example, some kind of positive result on a test, a urine test or whatever, and you need to resolve it within 72 hours. If there's a report, well, I took an over-the-counter drug or whatever, not I had a prescription from a doctor and here it is, but I self-medicated because I had a sinus infection or something. How do you resolve that? Because that's where the rub is, I think, between a safety and helping service, safety and service. So
sure, that's a great question. So when participants enroll in monitoring, they're provided sort of a drug guide on medications that are safe to take versus not. And so in an instance where, so a positive result for us, we'd have to have a valid prescription, right? But in instances of over-the-counter medication, so we do require that a log be established of their daily medications. And I think we define it, I have to go back and double check of this specific time frame. But if someone uses a medication, let's say an antihistamine or something like that, we actually will ask them as part of that 72-hour resolution. We will ask them to receive written letter to OPHP verifying that their doctor has authorized for them to use that medication. So I think that's what we mean when we say sort of resolve the matter, is we want their treating professionals to be aware of their medications and to be a part of that. So the over-the-counter things don't happen often, but they are usually most related to an antihistamine.
I'm sorry, I didn't hear what you said.
The process is, if it's an antihistamine, we're asking their doctor to see them and write verification that it's appropriate for them to use an antihistamine.
Hey, Kelly.
Yeah, Dr. Schottenstein.
Hi, thank you so much. So along these lines, I was wondering if you have a policy in terms of how you manage a slip. If you make a distinction between a slip and a relapse, and how you manage the slip.
Yeah, so I'm glad you asked that question because I think I'm going to talk about it right now. So I guess just to sort of wrap up the relapse piece is that when it occurs, so typically what will happen, right? So we're getting them back into treatment, we're notifying the board, and then after some period of time, we're writing a follow-up letter just because we have more time to get the whole picture to the board. We can tell them where they're at in treatment, a little more information about the incident that occurred. And so even though sort of our obligations or requirements to the one bite don't really extend beyond that, so we continue to assist that practitioner in treatment. We're getting updates about their progress in treatment. And if the practitioner has completed treatment and there hasn't been an action or a resolution by the board, we're requesting that they re-enter our program as temporary monitoring until they can transition into the board's compliance. We just identified that as a safety or a safeguard to make sure there aren't any patient safety concerns surrounding that relapse. So to your question, Dr. Schottenstein, so something that has come up that I don't think it was really ever considered when the One Bite program rules were updated is really about this idea of what is a relapse, where it happens. So in the prior One Bites and in the board's processes for discipline for an impairment case, that treatment's required to be in a residential setting, right? Minimum 28 days residential treatment. And the definition of relapse specifically states that if someone relapses while in residential treatment, I'm definitely paraphrasing here, that it's not considered a relapse. So the complication with the new One Bite program allowing for individual treatment plans and multiple levels of care is that that practitioner may not just be in a residential treatment setting. But if the individual relapses while in treatment, by the definition, even though they haven't finished treatment, it's still considered a relapse if it happens in a level of care that is not a residential environment. And so just kind of in communicating with the approved treatment providers, we've had a handful of cases in this scenario. The treatment professionals don't believe necessarily that is really a clinical relapse, but it is a relapse based on the definition. So in those instances, we're reporting those to the board and allowing the board to make those decisions.
Okay.
I'm sorry, I'm not either I'm not hearing or I'm not understanding. It could be either and both. If a patient is in treatment, and while in treatment, I mean in a residential treatment, and he or she relapses, you're saying within a residential treatment, that is not considered a relapse?
That's correct.
If the patient is outside of a treatment facility and you are aware that some incident happens, that is considered a treatment, that is considered a relapse? Or I know there's gradations because we've had a case in which somebody has had a drink at his daughter's wedding, and he shouldn't be having a drink, and they had a champagne toast, and he had part of the champagne toast, and he's not in residential treatment. That is considered you're your clinicians do an artful interpretation of what is really. I mean, when I say artful, I'm being a little cynical, but an artful interpretation of what, or perhaps it's a professional interpretation that that's not a relapse if there's not anything that follows it.
Yeah, so I mean, you make a great point. And I don't necessarily think when we think of treatment is not just residential treatment. I think that's what we're trying to say when we have multiple levels of care and individualized treatment programs. One option is residential treatment. Another option may be part residential treatment, part intensive outpatient treatment, but that's still part of their treatment. And so I think we're just identifying that if someone is in their primary treatment, so this is before they go back to work, before they begin their continuing care, it's what the treatment centers are recommending for them to do as part of their treatment. And so if someone struggles in their treatment and it's not necessarily a residential setting, right now the way the definition is written is that it is considered a relapse, even though it's part of their primary treatment, the original treatment. I don't know if that helps.
So what you're defining is if they're not working, if they're not doctors working, and they have an issue, and they're not in a residential treatment center, in a residential setting, it is not considered a relapse. It is just simply part of the process of treatment and failure in treatment again.
So I would say yes, but maybe
so
the treatment that they're in.
Your pivot is work, not work?
No, I think we're just thinking of the treatment is treatment that's not necessarily just residential, right?
I get it. What is the check mark that says, okay, this is a relapse? I mean, your line, demarcation line is, okay, they're in treatment until they get to the continuing care. So, okay, so you've got they're in treatment, but they're not in their continuing care. Because the line of demarcation to relapse versus this is part of treatment is work, not work.
I think it's about completion of the acute or primary treatment. So if someone's treatment recommendation is to do 60 days of residential treatment, that would be their acute care. If someone's recommendation was to do 3 weeks of residential and then transfer and do 6 weeks of intensive outpatient treatment, that would be their acute care. So I think we're just looking at it in the context of what the individualized treatment plan is. So basically what's happening is we're just sort of forcing everyone back into that 28-day residential treatment model. And I think the hope was that it's not just about intensity of treatment, but it's about duration. So you can be an intensive 28-day residential setting, and someone could also do 3 weeks of residential and 6 weeks of intensive outpatient. And instead of having 30 days of treatment, all of a sudden they've got 2+ months of treatment that they're engaging in. I think we're just sort of acknowledging the fact that I don't know if this was considered to be part of the process, but it is definitely something that is occurring, and that it might be something that the board wants to take a look at in the future.
So when we look at your requirements, when we get to number 4, which is continuing care, there's the line. Once they start getting into continuing care and there's an incident, then we consider that a relapse as opposed to a slip, which is in the more acute stages, which is evaluation, complete treatment in and suspension of working. And that's where you're making your demarcation. I'm sorry, but I know you can't have a straight line, but I think as a monitoring, as a board, we have to understand clearly between the two of us what is
Yeah.
considered a relapse, what is considered a slip.
Absolutely. So just to be clear, we're not making that distinction right now. If someone relapses and it's not in a residential setting, we are sending those reports to the board and allowing the board to make that determination based on the definition. I think we're just saying in the future to take a look at what it means to allow for multiple levels of care, and that acute or primary treatment, which would be what's completed prior to continuing care. You're absolutely right about that. Maybe it just doesn't look the same every single time. So again, we're not at this moment asking for the board to make a distinction. I think we're just saying this is something that's come up, and it might be helpful to have a more in-depth conversation about it at a future date.
Mr. Giacalone, I saw your hand up.
All right, Kelly, and I hate to beat a dead horse. I just want to clarify this.
Yeah.
Residential, I got it. If something happens there, it's whatever we define it. It isn't a relapse. It's an event. You move along. And when I hear it's 28 is our default in the board, right? We go to 28 day. You're saying you have flexibility because you're making an assessment of the individuals. So it might be 15 residential, 15 intensive outpatient, right? So it depends on the individual. My question, just to follow up on Betty's, is a little bit of this. Okay, I'm in my 15-day residential, right? Something happens there, I get it. Not in relapse. Now I've moved into my 15-day intensive outpatient. We're still defining that, I think, as all treatment. So now if that event happens in the 15 days when I'm out, is that a relapse that's reported to the board, or is that still considered part of the overall treatment scenario and it's not reportable?
Yeah, so as of today, it is reportable.
Okay, it is reportable. Okay,
that's what we're just asking is for consideration in the future of what it would mean to allow for multiple levels of care. So in that situation, so today, that person who relapses on day 15 of their intensive outpatient treatment is reported to the medical board for a relapse. I think what we're looking at is just having a broader conversation about in the future, if that is their primary treatment, is that an opportunity for the practitioner to then get placed back in a higher level of care and continue the treatment process until they complete their primary treatment. So I didn't mean to go down a rabbit hole. I think we were just sort of identifying that. So this is how we would look at as perhaps a slip or a lapse, by the definition, or a therapeutic relapse if it happens during the context of their primary treatment. But we also understand that the rules are the rules, and so that we're sending the reports in such a way to sort of identify that clinically this may not be what the treatment centers think of as a relapse, but it is based on the board's definition.
Okay, so into your scenario, what you guys would like to see is if it was 10 days residential and 10 months outpatient intensive care, there'd be no reporting because that's all part of the treatment, right? That's the way you guys would like to have it. If that was the
so I think, I don't know if it's how we'd like to have it, but I think it would make sense if that is their primary treatment. So those safeguards are in place. They're not being eligible to return to work until their primary care is completed. And so I think if there were ever a time for there to be a relapse, it would be in a treatment center where someone can stay in a space and work on themselves rather than kind of veering into after that treatment is completed.
Okay, but what's to stop the clock from rerunning each time, though, if they're in the outpatient acute setting, right? I mean, you do 10 in, you do 10 months out, it happens, we restart the clock again, you're 10 in, you're 10 out, restart the clock again? What's to stop, potentially gaining the system and no relapse ever being reported?
So, I mean, I think there would be elements of the reporting requirement if someone's impairment is not substantially alleviated by treatment. If someone needs to spend 3 years in treatment, as long as they're not practicing, and maybe they'll never be a doctor again. But I think our understanding of the treatment centers that we work with and just feedback that we're getting is, this is a progressive, chronic, relapsing condition. And so we're asking people to complete treatment and then be perfect. So if there are elements, and what we see most frequently is this happening in an intensive outpatient level of care. And just as a reminder, so in this residential setting, you're kind of off into a facility in a safe environment that's structured. And then this intensive outpatient is intended to help people get acclimated to their home surrounding, identifying triggers where they are, establishing a support network around their home environment. And so it makes sense that that's where, people are relapsing. So, I mean, I think all of your questions are great questions, and the concerns, again, are valid. I think we're just hoping that we might continue this dialogue in the future to see if we can come up with either the same solution, but just really wanting people to understand the process and what it looks like a little bit more.
Okay, thank you.
Yeah.
Thank you.
Dr. Feibel, oh, sorry. Dr. Feibel, you have a question?
Yeah, I hate to, I know the time's running short, so I did have a question. It's about reporting. So it's related to this, but not totally. You said something, and maybe I missed it, about that people who are not eligible for the One Bite program if they don't have a substance use disorder diagnosis after evaluation. You said it was up to them then to report to the board, that you give them the option of reporting to the board or not. If they choose not to, do you report to the board?
If there is no diagnosis of a substance use disorder, no, we do not. Most likely it will circle back in an instance of either a license renewal if it was related to a DUI, or I mean, it's comparable. So we talked a lot about this in the implementation stages of the One Bite program, and it was really sort of left up to the individual practitioners. So if the board sent a referral to OPHP and they did that assessment, they were diagnosed with a substance use disorder, the board wouldn't be receiving that information either. And so it's really just a matter of communicating that to the practitioner. They can then send it to the board if they like, or if they authorize us, because it's not one of those carve-outs where we can automatically report to the board without consent. We're not able to report those automatically.
So if we refer something to you, we're assuming that it's in the One Bite program, but we don't know that for a fact because we're not able to see that. And then the practitioner never completes the One Bite program. The board never knows that, so never can investigate it. So that's a big problem, I think, with how either the statute's written, or unless I'm misunderstanding it, people are slipping through the cracks with that because we're assuming they're in the One Bite program because we referred it to you, and we have no way of knowing
in order
that.
to be eligible for the One Bite program, they would have to have a substance use disorder. And if there's the reports that we're getting are related to an impairment with a substance use disorder. And so if we're sending them to those evaluations, I definitely hear your concern in feeling like every case should be accounted for. And I know we started implementing monthly meetings with the board staff, and we might be able to look at ways that we can account for the closed cases, being mindful of the reporting requirement.
Otherwise, that person really doesn't have a substance use disorder. It is not up for disciplinary action from the board because we never know about it. So we've assumed that it's now passed on Ohio PHP and never hear any feedback back because we can't. And we have no idea that that person wasn't even eligible for the One Bite program. We assume they're in the One Bite program.
Yeah, and I mean, I definitely, like I said, it is a valid concern, and I think we have a monthly meeting in the next couple of days. So perhaps Stephanie and the group, we can have that conversation about, making sure that if they are not eligible, wanting to make sure that that sort of case is tied up with the board. Yeah.
That makes sense. Kelly, might I suggest, for the sake of time, we're running toward the end here. I know you have a couple of case examples for us, and you're going to talk about some maybe future evolutions of the One Bite program. One of those we just talked about, which is that definition of relapse. What I would maybe suggest is that we bring those case examples and those other discussion points to our November compliance meeting, perhaps, and have you maybe join us at that November compliance meeting. In the meantime, I do think it might be helpful if you skip to the end where you really highlight for us. I think it's important for the board to hear from you what you're seeing in light of the pandemic. It's something that the MAC has brought to our attention. It's something that you've brought up in our monthly meetings, and I think it would be helpful for the board to hear as well.
Yeah, great. That sounds excellent, Stephanie. Thank you. So just to sort of close, there really wasn't much information that wasn't reviewed that hasn't already been presented to the board. But we're really seeing just a general disruption to what is traditional proven recovery support. So your AA community, your caduceus community, pretty much everything is being done online. And I know there have been some meetings where they've gone back to an in-person environment, but I know people are already gearing up for a second wave, and I would anticipate that to be pulled back a little bit in the next couple of months. Another thing that we've seen is just issues with testing sites, having reduced hours, reduced staffing, some of the sites not doing testing at all because they're exclusively doing COVID-19 testing. It's not as bad as it was, but that was something that we had to address. And then another one, which is a really big one for us, is the treatment centers have had to adapt. And what was traditionally done in person in a group setting is now being done like this. They're virtual, and we just don't know the unintended consequences of this disruption of what is sort of a tried and true process of recovery. And so we're seeing, again, just because there's pre-screening and things like that, there is a delay in getting people into evaluation and treatment. It used to be something we could make calls and get them in right away. And now there's pre-screening and, just extra steps that have to take place. So just kind of what we're seeing directly is just an increase of everything. An increase in people relapsing. I would imagine that 92% is going to go down. So we're seeing a pretty substantial influx in relapse. We're also seeing a huge increase in stressors, people needing assistance with mental health disorders, people struggling with burnout, and just the individual stressors the pandemic has presented to the medical community as a whole. And then unfortunately, we've seen an increase in suicidal ideation. That's not something we ever want to see, but unfortunately, it is the reality. And I don't think it's anything unique. I mean, I would say that the medical community is facing this head on in a direct way, but I think these factors are sort of across the board. I think across the nation, just in general, we've seen relapse go up, mental health disorders go up, suicide rates go up. And so, just with that, I know we're short on time and we can certainly bring some of the other information back to the board, but I really just want to thank you guys. I know you have a big, long day of allowing me to sort of dive into the One Bite and really dig through the information. And we really take seriously what we do and want to make a good program, and we'll continue to work with Stephanie and your staff to make improvements for the program. So with that, I don't think we have time for questions, but look forward to following up with you guys in the future on this topic.
Well done, Kelly.
Great.
Thank you so much, Kelly.
Kelly, thank you. Thank you so much. We really appreciate it. And we'll see you at our November meeting, I think, if you're agreeable. So great.
That
All right.
sounds great. Thanks, everybody.
Thanks, Kelly.
Thank you, Kelly.
We are going to take a 15-minute break, if okay with all of you, and we'll jump back on here about 10:15. Does that sound good? All right. Great. Thank you.
All right, the live stream has started.
Great. All right. Welcome back, everyone. We're going to move on to our next presentation, which is the role of the secretary and the supervising member. Before I begin that, I do want to let you know the presentation materials are available in Onboard. Those are loaded for you. And so if you want to look at those, as we go or afterwards, you'll have access to those presentations. So Kim and I will be doing this presentation on the role of the secretary and supervising member. We thought this was timely for a couple of reasons. I've been sort of keeping track of the different questions that we receive from board members during the meetings, and again, as you all are preparing your board materials. And I think, a bigger picture understanding of the role of the secretary and supervising member is important because they oversee so much of the day-to-day work at the board. Additionally, the FSMB report that we had done this past summer that we shared with you in August highlights the role of the secretary and the supervising member as one of their recommendations, and actually recommend some modifications to that role. We're going to talk a little bit more about that in the FSMB report. But before we do have those bigger conversations as a board, I think it's important for us to understand where we've been and where we're headed. As part of this, we'll go through the history of how the role was created and what functions the secretary and supervising member played then versus how it is now. Kim's going to walk you through, I'm going to provide that history, and then Kim's going to walk you through really how the role works, how we operationalize that. And then of course, Dr. Rothermel, Dr. Safran, and Dr. Bechtel, with your experience, please feel free to if we're getting something not quite right, or if you want to make a point that we're not illustrating very well, please feel free to jump in and advise. So again, just a preview of our agenda today. So we're going to talk about how the roles were created, particularly the modern role that we know it today, what those roles do, what does it mean when we say supervise, and really what's the difference between the secretary and supervising member and the rest of the board? How do those roles differ? What are the expectations of the members? So how we got here. We sort of put a little bit of a history lesson together for the board. And so some of you probably know this, and I apologize if it's redundant. I think some of you don't, because I've had conversations with you and you weren't aware of some of this. So hopefully it's educational at the least. In 1985, the Cleveland Plain Dealer had an article, and can everybody see my screen okay? I just want to double check. Okay, great. In April of 1985, the Cleveland Plain Dealer did an article. It was a series of articles over multiple days, rather sensationally titled "Doctoring the Truth." And it was this sort of expose of the medical board. What we learned as we were looking into this was there was actually an article done in 1980 And so this 1985 article was somewhat of a follow-up. It wasn't, I guess, just out of the blue. There was an article in the 80s, some changes were made to the medical board, and then they came back into this big series in 1985. We have that available if anybody would like to read that after. It's about a 50, 60-page article, and broken up topically by day. And some of the things that they were highlighting were sort of this idea of secret board meetings. Disciplines and meetings were being held in secret. The board's discipline, the article highlighted, was too lax on providers. According to the article, there was this pervasive failure to remove bad providers from the system. And really the last day of the series kind of highlighted the reputation of the medical board amongst other regulatory boards in the state. And it really paints this picture that the medical board was sort of this not concerned with protecting the public, but more concerned sort of with protecting themselves, and really had this reputation amongst the other boards as just not being as serious about discipline as some of the others. And they had some statistics in there as well. One of the highlights throughout the article was about the board's administration, the internal administration. They talked with legislators who really had a hard time working with this administrator. The staff really didn't think much of the administrator at the time. And so there were, obviously, this was sort of one of these big blow-ups of you have to do something, state of Ohio. And Vern Reif was the speaker at the time, and he jumped on it immediately. And, you know, as one would expect, appointed a commission and pulled a big study together. So in response to that, there was a series of meetings at the medical board, and files were reviewed, and staff was interviewed, and LSC came up with a 50-page study. So we have the 50-page plain dealer article, and then we have a 50-page LSC study sort of on the operations of the medical board. And the LSC study broke it down into two categories. They looked at the administration of the board, and then they also looked at the discipline of the board. And this was all done in that same year in 1985. Administratively, the findings were very similar to what the article highlighted. There was an emphasis sort of on weak enforcement. The LSC study really dove into probationary matters and how we handled probation at the time, and a concern with compliance amongst probationers. But the overarching theme, I think, in both the LSC study and the plain dealer article, it was this emphasis that the board did not really see itself as protecting the public. And they went through minutes, and they went through staff interviews, and they went through files. And I think the theme was, you're really, really good at licensure. You're good at getting people in the door, but you don't see yourselves as the protector of the public. And then with disciplinary findings, they talked about the inadequacy of the sanctions that were being issued by the board. Again, that probation monitoring. They actually hit a little bit on the challenges of the board having cases prepared by enforcement attorneys and then quote prosecuted by the attorney general. So a system that we actually still have in place today. And finally, again, not taking action on incompetent providers. So LSC really backed up what the plain dealer was saying with their review. In response, then, the legislature looked at that LSC study and said, okay, it's time to make some changes to the medical board. So this is when we had our next, actually this says second consumer member. I didn't say this. This was actually the addition of the third consumer member. The qualifications on this consumer member were the same as one of the other consumer members, which was that there cannot be a connection to a healthcare provider or profession. So this was actually the addition of the third consumer member in 1986. This was also when the secretary and supervising member roles were created as we know them today. And also that emphasis that we're retaining from the recusal from adjudication. We had an appointment of an attorney hearing examiner position. This was formally done by a board member. So this was really to create that independence and to get out of that, what the plain dealer had characterized as that sort of secret setting where board members were meeting with licensees behind closed doors, one-on-one, maybe with a staff member, and making disciplinary decisions. So this created the role as we know it today with the attorney hearing examiner. Again, with the emphasis on the lack of taking action, this is when we saw the creation of the automatic suspension for certain criminal offenses and the creation of what we know today as the summary suspension. There was a tool for summary suspension available prior to this, but you had to go to court to actually exercise it. And we were one of the only boards who had our structure that way. And so that we have the modern structure now where the board can take action and do that summary suspension. And finally, then in 1987, we see that the board, in some of the board minutes, some discussion on what LSC found in their study, what the response was from the medical board, and also some discussion on the role of the secretary and supervising member and what that role would now look like in operation, right? So 85 was the study, 86 was the legislation, and now you can see the board sort of talking about what those new roles look like in 1987. I'm happy to share that 1987 response to LSC with you. It's actually quite sensational from the medical board. I don't imagine we would ever do something today, but they were very, I would say denial was a common theme in the LSC report, but nonetheless, they decided to take some action and go forward with some of the recommendations and actually operationalize the new statutes. So in response, this is where we see the secretary and supervising member really have their role created where they are identifying the complaints, closing the complaints, where staff is only making a recommendation. The secretary and supervising member are reviewing that entire body of closed complaints, that the secretary and supervising member are authorizing investigations, and that the secretary and supervising member are authorizing office conferences. Interestingly, in the minutes, there is some dialogue about the creation of the role. And we actually have a copy of that discussion paper memorialized in an old secretary and supervising handbook, the one that the board adopted in 1987. Interestingly, some of the conversation around the creation of the role was, well, if you have the secretary and supervising member doing all of these things, then what's the role of the rest of the board? What do you have us doing as fellow board members? And this is where we really see that theme of we have board members as adjudicators, and we have these two roles carved out as enforcers, right? And so, and as explained at the board meeting at that time, that was really the explanation. We need to have two board members who are actively engaged with shepherding complaints through the process, and then we need to preserve the rest of you to serve in the adjudicatory function for our licensees in a very public format. And, you know, thinking back and understanding the context of it, I think that's important for us to remember that so much of this was done behind closed doors prior to these changes, that this system really modernized this concept of we have two board members overseeing the internal, and we have the rest of the board then serving in that adjudicatory role with a neutral public hearing examiner available. So that's a little bit of background on kind of how we got to where we are today. I'm happy to answer any questions now before I turn it over to Kim.
Stephanie?
Yes.
When did we start deliberating in public?
So I think it was I think it was around, I think there was always some degree, from what I'm seeing from minutes, I think there was some degree of public adjudication. I think that the process became more formalized into what we know it today at this time period. I think there were a lot of things happening behind closed doors that when you read the medical board's response, it was really a description of, well, these are inter-office conferences. These are things we need to do with probationers behind, or with licensees behind closed doors. But what was happening was there was no formal role to handle that. It was individual board members sort of taking that on a rotating basis. And so really a lack of kind of continuity and structure to the process. But I think what we would say, what we know now and how board actions are taken today was really started in this like mid 1980s time period.
Thank you.
Yeah, great. Okay, Kim, I'm going to turn it over to you, and I'll keep clicking through your slides if that is good with you.
That works. That's great.
Great.
The next section, so the next slide, we're going to talk about the scope of the roles of the secretary and supervising member. And so what I'd like to do is just kind of give you an idea of the statutory requirements around those roles. And I think sometimes it's helpful just to kind of see, what's required by statute, and what do we do because we're required to by law, and then what is part of our practice. So I think these slides kind of help with that. So first, talking about the board secretary. So the board secretary, in essence, is responsible for the enforcement of the board's laws and rules. And the board secretary must be a member of the board. I think originally in 1987, when they did this, the statute didn't even require the board secretary to be a member of the board. That changed over time. So the secretary is required to be a member of the board and is required to be a physician in good standing. So I know sometimes when we're appointing, like where there's a conflict and Dr. Schottenstein appoints an acting secretary, it's always important when that happens that individual has to be a physician. And that's because that's statutory. I've cited all the statutes for you for anyone who's interested to go look at them, and I can also provide them to you. And I think what you'll see is the statutes are in every section. So we have different statutory sections dealing with different license types, and these particular provisions are carried over into each section that the board has. So the secretary and supervising member roles work for all license types equally. So that's what that means. But also, as you know, the board secretary is elected for a one-year term. And that's something that you do in December of each year. So the other thing that's interesting with the board secretary statutes is the board secretary can actually make a referral of a probable cause violation of the board's statutes to a prosecuting attorney of the proper county. I don't think that's something that we exercise too often, but that is something that the board secretary can do. So they do have some enforcement power like that, in addition to our administrative work. So next slide. And we'll talk about the supervising member. So the supervising member also has to be a member of the board and is elected by the board for a one-year term. There are no other qualifications on the supervising member. And as many of you know, we have had at least one consumer member that I'm aware of that served in that role. So that role is, does not have to be a physician. All right, next slide. Again, in all of the statutes around investigation for all different license types, the secretary and supervising member together are responsible for supervising investigations of alleged violations of the board's laws and rules. And this is set out in the board's kind of statutes that set up our investigative processes. So next slide. Another really important statutory requirement, and I think these questions come up quite a bit, is the secretary and supervising member and anyone else who serves as overseeing the investigation of a case. So an acting supervising member, an acting secretary may not participate in the further adjudication of the case. And I think you see that comes up with Dr. Bechtel, who's previously served as a supervising member and a secretary, that he is then prohibited. So on matters that may have been pending when he was the supervising member or the secretary, or related to those individuals, he can't again serve as adjudicating the case. So that's why he has to recuse. And I think that's why you see that in the board, that, you know, there are recusals. And this requirement, again, is contained in every single chapter of the board's statutes. So it is a statutory requirement that the secretary and supervising member cannot participate in that adjudication of the case, the investigation. And we'll talk a little bit more about that as we go on. But I wanted to show you that and show you the language and, you know, kind of what that looks like and where it shows up. All right, I'm ready to move on then, unless there's questions here on the statutes, to more of the practical application of the statutes to the secretary and supervising members' actual work. So, you know, what does it mean to supervise an investigation? And so what it is the secretary and supervising member review the complaint decision points. And then the next question is, what are the critical decision points? So I think the best way to show that is to give some examples of the places where the secretary and supervising member are involved. And that doesn't mean that they can't be involved in other ways, but these are the typical when staff will consult with the secretary and supervising member. So they're reviewing the reports from the investigators, so the ROIs or reports of investigations, and then making a decision based on the investigator's recommendation. They're reviewing reports from the nurses in standards review who have reviewed medical records related to the complaint. And then they're making decisions about what do we do next, you know, after reviewing that. They're approving cautionary letters to be sent to licensees. So this serves as generally closing a complaint, but it's notifying the licensee that a complaint was lodged, there were potential issues, and making that licensee aware of the relevant statutes and rules that were at play, and it also lets them know we're closing it now, but if we get other allegations, we will reopen. So this is a letter it's not public, it's part of the confidential investigation, but those are reviewed and approved, recommended by the secretary and supervising member. They also participate in investigatory office conferences. So sometimes there are complaints where the secretary and supervising member think that they would like to speak with the individuals to get more information, to talk with them about expectations and the requirements. And so they schedule that. They have it with an attorney as well, who is present, and they provide a notice to the individual that says basically, very basically, what they're going to talk with them about. And then you'll see some information later in this presentation about, what can happen after an investigatory office conference. The secretary and supervising member can say, okay, I think we understand what happened here, and it's not a violation that's rising to the level of discipline, so we'll close it with a caution letter. Maybe they'll say, hey, be mindful of this particular issue, like make sure you document things really well in your records, or things like that. Or they can move it on for further investigation, or move it on to enforcement. So there's, it's really just an information gathering for the secretary and supervising member to actually meet with the license and gather information in that way. They also review the affirmative questions to licensure applications. So on licensure applications, there's a number of questions which, if there is a yes answer, it triggers a complaint. And the secretary and supervising member look at that and decide, should we open a complaint on this and move forward to investigation? Or, are we, a lot of times we're also asking for information from the licensee to explain those yes answers. And they're saying, does this satisfy us, their explanation, or do we want to check it out further and have investigation? Or is it rising to such a level that we want to send it to enforcement, that we think a violation occurred here? They're answering questions related to malpractice, criminal convictions, impairment issues, and issues like, other state actions, or issues in their residency or training. And so those are kind of the things that they're looking as to how to move forward with that. They also review the probationary requests before you see them. And I think from compliance committee and from your board materials, it will say on there if the secretary and supervising member are in agreement with those requests. And they also meet with probationers as well, along with staff, when there are issues, or I think when they're getting close to being released from probation. All right, I'm ready for the next slide. Here's some more critical decision points. So as you can see, there are a lot of different areas where the secretary and supervising member are involved, and I think it's they also vary, as to which stage it is, what their level of involvement is. So next, these are more enforcement type critical decision points. So they're reviewing and approving the selection of expert reviewers and expert witnesses. So when you see a minimal standards case that has an expert witness, the secretary and supervising member have been involved in reviewing their qualifications before they were selected, and then reviewing their materials and deciding, what to do with that. They review and approve investigative subpoenas. You'll see that is one of the higher volume things that we have. And actually, by the statute requires the secretary and supervising member and the assistant attorney general to review those documents when they're related to patient records. So that's an important oversight function that they have. You know, I think to ensure that our staff is properly preparing those subpoenas, because that is a really powerful tool. Then next, they're reviewing and approving requests for mental and physical examination of licensees. This includes the 72-hour impairment evaluations, as well as I think you see examinations from time to time, like from Dr. Knopfsinger, and related to physical and mental conditions of our licensees. They review the draft citation letters, the notices of opportunities for hearing, and determine the settlement terms. So at that time, when those are being approved, both by the secretary and supervising member and the assistant AG, the secretary and supervising member are setting the terms about what they would want to see to settle the case. So I think that's important for you to know too. When you see post-site settlement agreements, those terms have been approved by the secretary and supervising member, and that happens at the time that the notice of opportunity is prepared for the board. And then they review and approve summary suspensions. And I think you'll have a presentation a little more in depth on that later today. And then they also review consent agreement proposals. So they're reviewing the post-site ones, but they're also reviewing the pre-site proposals from the enforcement attorneys. And I think you also know that if those proposals go below the minimum disciplinary guidelines, then that has to be reviewed and approved by the board president. So that's in one of our hearing rules, requires that. So that's a safeguard too, that the secretary and supervising member are tied to that, the minimum disciplinary guidelines established by the board. And if they're going to go below those, they have to have the board president come in and also review that and approve it. So next slide, please. So we created a chart that shows you just some volume on the critical decision point statistics. You know, you can see they're approving typically over 100 sites per fiscal year, and consent agreements are a bit behind that. We're seeing in fiscal year 18, consent agreements and sites were pretty even. Fiscal years 19 and 20, settlement agreements were in the mid 60s, while the sites were higher at over 100. We're seeing, you know, experts reviewed fiscal year 19, and I think I'm not exactly sure what the reason for that was, but that's something that we can explore further. I think these experts also would include the case reviewers for the sexual misconduct cases. And you can see subpoenas are certainly a high volume item for the secretary and supervising member. For fiscal year 20, they were at over 1,500 subpoenas. And that's something that happens pretty typically in a minimal standards case. A subpoena for the medical records is going to go out right away, so that those can be reviewed, you know, because that's really the best evidence for those types of cases. And then we've talked a bit about.
I have a quick question. I have a quick question about that.
Sure.
So when you say that the subpoenas, 1,500 subpoenas that they're really reviewing well, seems like a lot of subpoenas to look over and make sure that they're accurate and correct. So if there's a medical board complaint against the practitioner and they request medical records on that practitioner, is that being approved by the secretary and supervising member before that goes out?
It is, yes. And
So,
I don't,
so almost any complaint they will have to issue a subpoena on almost all the time. Is that should mirror pretty closely our complaints, unless it's like I waited too long in the waiting room or something like that. I mean, obviously, those get dismissed without that, but the majority of the real complaints, they have to issue a subpoena for the medical records.
yes. So we do have a process that if complaints are going to standards review, so like for a nurse review, they're going to request a subpoena right away. If a case is going for investigation, that's going to be at the discretion of the investigator. But if it's assigned to the nurses, because they have to have those records to review, as soon as that's assigned, it goes to administrative person to develop the subpoena, which has boilerplate language. And then the secretary and supervising member and the assistant attorney general will be reviewing what's being requested in that subpoena. So like the patient key, the number of patients that they're looking at, the time period that they're looking at, and that's reviewed by the secretary and supervising member, and that has to happen before it can be issued. And I don't know if any of the secretary or supervising member, Dr. Bechtel, have any comments there about that process.
I mean, that's a good review and summary. It is very work-intensive position because it's a very serious position and it takes a lot of time to review. So it is you can tell already, a very work-intensive position to hold.
I have a question.
Sure.
If I may. So I'm looking at these numbers in terms of consent agreements approved and citations approved. And I wonder, in terms of our workload and our processes and our efficiency, if we have a sort of rule of thumb in terms of a ratio that we're looking for, because that is a lot of, citations as compared to consent agreements. I wonder if we would be right to try to, maybe with additional, training on settlements and things like that, shift that a bit so that we are having more consent agreements and fewer citations, if we have a thought in mind as to what feels like a reasonable proportion of each.
Sure. I think that's a great question. I think the FSMB report touched on that a bit. I don't have a number, but I'm sure that's something that we can explore. I'm just probably not the person who would come up with that number, but I think that's a really good point that a notice of opportunity for hearing then contains a ton of additional work. And a consent agreement is done at the point that it's ratified, and then the work is on the compliance with it. So I think that's a great point that you're raising, and definitely worth further discussion.
Dr. Schottenstein, I think you're absolutely right that we should be working hard up front to avoid 3,000 or 4,000 page transcripts on a hearing that takes takes most of the week. I would want to be very careful about setting any ratio. I mean, we'd have to be very careful so that we don't look like we're setting a quota. But I think that goes to something we've all talked about, is the upfront. Let's grab this case early and see if there's a way to settle this, if it's an appropriate case for settlement. I agree 100%.
Okay. So on your next group of slides, and you also have this in your materials, so it may be easier for you to look at it in that way, in Onboard. So this is just kind of a workflow And we've got 3 different sections here. So this is a workflow for the licensure cases. So we talked a little bit about how the secretary and supervising member are looking at those licensure applications, the affirmative answers. And so this kind of walks you through, you know, what happens in those cases and where the secretary and supervising member is involved. You know, if a case is going to be closed, and I think we'll talk about this a bit more as we move on, but the secretary and supervising member really need to be involved with that, because unless there's a protocol, they're determining whether a matter should be closed or not. And that's a big safety, kind of a safety mechanism, so that board staff is having that additional review before a matter is being closed. And that's something that goes back to you know, the 1987 concept, secretary and supervising member involved in that. So you can see here that if, you know, there's a yes answer on a license application, it's going to go through the licensure triage process, and then it's going to go to the secretary and supervising member there for review. There are some protocols in licensure, and so they are able to utilize those and close a complaint based on a yes answer, based on protocols that have been developed with the secretary and supervising member. And supervising member also can say, we're going to route this into the normal complaint process and move it on to investigations to find out more information, to enforcement, because what they've told us in the application is so concerning, and you know, it's a violation and we don't need much more information, then that could go straight to enforcement. It's possible we could go to standards review. That's less likely from licensure, but if there were some sort of malpractice or you know, a privileges issue that was reported and we wanted to get more information about that, that could go through the nurses to review through the medical records. So that's just sort of an overview of a license complaint process. And Dr. Bechtel, did you have a question?
Yes, I wonder, Kim, if you could discuss what happens when reviewing a case to either close the case or to go ahead and do further investigation. The process that happens when the supervising member and the secretary disagree.
Oh, sure.
One close and one says, I want to investigate. Where do we go from there?
Sure, that's a great question. So, so we have to have agreement. So for the staff, we can't move it on. If Dr. Rothermel says, send it to investigation, and Dr. Safran says, I want to close it, we have to work that out. So, so it gets assigned to probably an attorney. I know I do them sometimes. I think James Roach probably does those sometimes at the investigative stage. And so the case gets assigned to us, and then we go meet with the secretary and supervising member. We're doing that virtually now. And we meet with them and say, okay, you have to come, you have to agree. And so we'll have a discussion. We'll talk about the particulars of the case, what we know so far, and then they have to come to an agreement. And they're very good about doing that. But it is a step where kind of takes it out of the process a little bit, and then, you know, we have kind of a discussion with a staff person, you know, typically in a manager role, and with the secretary, and then they come to an agreement and we move on from there.
How was that determined? Is that a statute-oriented thing, or is that by just tradition?
Well, because the secretary and supervising member are responsible for overseeing the complaint investigations and the decision complaints, they both are responsible for that. So, so the way we've interpreted that as staff is we can't move forward just based on one. We have to have both. And so that's why you get an acting secretary and supervising member. So if the secretary or supervising member have a conflict and they can't make a decision on a particular complaint, they don't feel comfortable doing that, because of a potential conflict issue, then we have to get someone else to come in and do that so that we have the secretary and the supervising member. And I think that was designed also as a safeguard to make sure, you have accountability. You have these two members who are independent, who are reviewing what the staff is recommending and the matter that they have in front of them. And so I think that's why that's in place. It's an accountability issue.
Because I would think that that's important to have both two people. I agree, but my philosophy, and again, I don't know what this would do to the numbers, so I'm hesitant to say it. But my philosophy would be that if one of the two of them thinks that it needs to be investigated, it should go on to investigations to protect the public, as opposed to one trying to strong arm the other. And again, I'm not talking about our present supervising member and secretary, just in general, that one's trying to convince the other about why they're right. I think that's a little dangerous and potentially where the system could fall off the rails a little bit. Just my thought. And again, if it's designed by statute, then that's one thing. But if that's by just tradition, it might be something we want to look at some point.
Sure, absolutely. And I think it's anyone else? Okay, let's move on then to the next slide. So we're still in the workflow, and this is more of the basic complaint workflow. So a complaint comes in, it goes, this is not coming from licensure, it's coming through the portal in Salesforce. It goes to administrative triage. I think we've talked about that before. That's one of 5 attorneys who's reviewing the complaints as they come in. And then typically it's routed to investigations, enforcement, or standards review. There's some protocols around what goes to enforcement, i.e. if something's already open in enforcement, the complaint's going to go to the enforcement attorney. There's some, certain like impairment issues that are admitted, self-reported by the individual, might go straight to enforcement. Most of the rest is going to go to investigations or standards review. If you look at the drop-down piece, underneath triage where it talks about the open complaints meeting. So we do have a process where we can do a desk investigation where the individual who filed the complaint is asked if they're comfortable releasing that to the person that they filed against. If they're not, we don't do it. But if they are, then we would release that and send it to the licensee. Typically, this is done for physicians and PAs, and then ask for their comments back, reacting to the complaint. And this is usually a lower level complaint that's not alleging serious minimal standards concerns or criminal issues or things like that. It's more based on I had to wait a long time in the waiting room. I didn't get good communication related to my visit, like those sorts of things. And then those responses come back and are reviewed again by the triagers, and we meet once a month and say, we think this should close. And then, when we send it to the secretary and supervising member, if we think that the physician provided a satisfactory response, if we feel like the response was not satisfactory, then we'll we'll ask for, more investigation, or, this looks, maybe we want a caution letter on this one, or, something like that. So after that open complaints meeting, then it goes to the secretary and supervising member. Those complaints typically close, not always, but more often than not, I think, just because of the nature of them to start with. So that's kind of your drop down level here related to, and if we could go back to the complaint workflow again. Thanks. So it's kind of that drop down grouping. And then if you go across the top, that's probably our more standard, the complaints that you see as a board have probably routed in this way. So they come to the triager, they go to investigations, enforcement, or standards review. We decide if we need to subpoena the records. As you know, in a lot of cases, we will. And then it goes to the secretary and supervising member to approve that. Then they may want to route somewhere else, after they get the investigative report. And then, they can move forward for an office conference. After the office conference, they could move that for more investigation, or to enforcement, or to close. They could decide to move forward to cite the individual, or to do a settlement agreement. And at all those decision points that we discussed, it's going to come back to the secretary and supervising member. And then next, we could talk about the probation workflow. So this is individuals who are on probation. So they've already gone to you as the board, and you have either approved a consent agreement, or you have approved a board order. And so then they have like their initial appearance with the secretary and supervising member and the compliance staff. And then, they move forward. If they have an issue with their complying with their consent agreement, then it's going to come to the attention of the secretary and supervising member, and they'll be making decisions based on the board's processes. If they're going to toll the probation, make them be on probation longer, or if they're going to have an office conference and try to find out more, or if they're going to send it to enforcement to move forward, or if they're going to close it at this point. So, so you can see that the secretary and supervising member are involved from the very beginning at the licensure application process all the way to the end for individuals that are on probation. And I think we've pretty much hit this, but a definite safeguard is that the secretary and supervising member are involved with the closure of really most of the complaints, except for those that can be closed via a protocol that they have approved, or it's gone through a board order or a consent agreement, and you, the board, have approved that. The underlying complaints from those formal actions will be closed based on the board's action. So that for really all other complaints, the secretary and supervising member are reviewing and saying if they're comfortable with closing it at that point. So I think that's a definite safeguard. And then just some kind of administrative responsibilities for the secretary and supervising member is signing consent agreements and permanent surrenders or denials after the board ratifies them. So they go out under the signatures, and they also are involved with approving any hearing continuances for matters for which there was a summary suspension. So if there was a summary suspension, the secretary and supervising member are required to approve any continuances. And then the secretary is responsible for signing board orders and dismissal entries.
Can you tell us who approves other continuances or the, I mean, what we've often seen is that we get serial request letters sent out and no response, so we send another letter out, or we send another notice out, or another subpoena out. I know in the hearing process, the hearing officer grants those continuances, but before that, all those other maybe duplicative processes, are those all approved through the supervisory members?
I don't know 100%. So one, the hearing examiners are acting in accordance with these case scheduling orders that they develop, which allows for some continuances based on requests from the parties. I think on an informal basis, the AAGs check in with the secretary and supervising member when continuance requests come in, but I don't know that 100%. And if it happens 100% of the time, but I think that happens. And I don't know if anyone else wants to jump in and
what about duplicative number of, we send a subpoena out, there's no response, we send the same subpoena out again, or we send things out multiple times, interrogatories.
Okay, sure. Okay. So that's prior to you getting to the hearing unit. I believe that the enforcement, so those are things that are happening in enforcement. And, my understanding is that the enforcement attorney would be checking in with the secretary and supervising member, so to let them know what's happening and ask for information on next steps. I don't know 100% if, every single time, like if there's not a response to interrogatories, if they're going back to the secretary and supervising member, or if there's a kind of a protocol that's been put in place to say, try 2 times and then, bring it for a B34 failure to cooperate site. But I don't know the answer to that. I think it may follow those paths.
Rebecca,
if anyone else knows for sure, let me know.
Rebecca would know, I think.
Yes, Rebecca would know. So Kim is right. It actually can go on either one of those paths depending on your situation. So when we're doing a case that we think is likely to end up in a failure to cooperate, we will always send them at least twice, just to make sure that, to be fair, that there wasn't a mistake with the first one, that they didn't forget, and also so that when you get to the hearing, you have enough evidence to support that they actually did not cooperate versus they just didn't get the first one. So those cases, that's why you're seeing those repeated. In other situations, we will discuss with the secretary and supervising member if the first set of interrogatories is not responded to, how they want to proceed. Sometimes we subpoena them in for an office conference, kind of lecture them and make sure they're on board with what the the board's expectations are for cooperating. It's really very factually specific outside of the failure to cooperate cases. But we do check with the secretary and supervising member about what paths they want us to take next and whether or not to escalate things.
Thank you.
You're welcome.
Thanks. All right, so moving on, and I see we're at the end of our time, so I'll try to move quickly.
Dr. Feivel might have had a question.
Oh, okay, I'm sorry.
It's okay. I can wait till the end. I know Dr. Schonstein had a question too, but.
Oh, okay, I'm sorry. I did not see you.
No worries.
Okay. So basically, and Stephanie talked about this at the beginning, the roles are just doing different things. So the secretary and supervising member are overseeing the enforcement function of the board and the investigation functions of the board, while the board members themselves are completing the adjudicatory or quasi-judicial function. So, you're hearing the evidence and making a decision about the final discipline for somebody. And so it's really just a different process. It's the kind of the end of the process that the secretary and supervising member have started. And then next slide, please. So by statute and for fairness, the secretary and supervising member are not allowed to participate in the board deliberations because they know a lot of things, and not all of that probably got into the hearing record. The board members are confined to the hearing record in making your decision, and that's under statute, chapter 119, administrative law, that you need to make your decision based on the hearing record, based on the evidence that's gone through the processes of cross-examination, and review by the hearing examiner. And the hearing examiner is reviewing witnesses for credibility, and so you're reviewing that. The secretary and supervising member is involved with deciding what to bring forward and what evidence to bring forward to discipline. And as you can see, a lot of other things too, like what information are we interested in coming from the license applications? And, what information are we looking at based on probationary compliance? And really all the steps in between. So I guess, just to leave you with, the roles are really very different. They work together well, but the secretary and supervising member are charged with, doing some different things, overseeing the investigative details, and making sure that the board staff is putting together the disciplinary cases to bring to the hearing unit and then to the board for the final decision. So I think that's all that I have. And I don't know if I know we have some people with some questions. I don't know how much time we have for that, but I'm happy to entertain them.
Yeah, I think we can allow a few minutes for questions. I'll keep an eye on the clock, but maybe if we go until about 11:30, it'll be fine.
Okay, great. Thank you.
Go ahead, Dr. Feivel.
Or Dr. Schottenstein?
Dr. Feivel, please.
Oh, okay. So I had two things, and they're somewhat related. The secretary and supervising member review draft citation letters and determine settlement terms. Review and approve summary suspensions and approve consent agreements. Is that by statute?
No, I don't think so.
Okay.
There's a rule. There is a rule that talks about consent agreements.
Okay. Because then we're being asked after they approve them, and then potentially if it's not up to sentencing guidelines, the president is asked to approve them. And then they're brought to us to ratify without everything, all the information. So I think the board personally, and again, I haven't looked at all the statutes, so I'm saying this without really having total knowledge, but to me, I think we're looking at this very narrowly. And yes, we can't participate in it's very clear we can't participate in the disciplinary disciplinary investigatory process. But to me, there's no reason we can't be given a full file of things that we would be given at hearing at R&R, similar to that, to make decisions based on. If I'm ratifying something that two people are deciding, and I have exceedingly limited information or no information or virtually no information, I'm uncomfortable with that as a board member. So this is an area I think we should look into. I realize the differences in the two members. I mean, the supervising member and the secretary and what their role is compared to the rest of the board. But I think we're taking a very narrow focus as to what the rest of the board is allowed to see. And so I would ask the board to maybe look at that along the way.
Okay.
Thank you, Dr. Fowler. I guess if I may, I have a thought about that, which is, as president, these consent agreements come my way when the recommendation is below the minimum disciplinary requirement. And, by and large, I don't have any special access to any additional information either. And so, unless it was something especially egregious, I'm generally going to wave these through because I don't want to gum up the works, right? If I start, picking at different things that maybe I would have done differently or things I'd like to know, all of a sudden that's going to grind everything to a halt. And so I'm just letting you know that practically speaking, my, predisposition is going to be, to grant these. And then secondly, I had a question about the investigatory office conferences, if I may. One is, when these licensees come in for those conferences, are they represented by counsel? And two is, are the deliberations in those conferences admissible, for our review?
So yes, if they want to bring counsel, they are welcome to do that. And that probably, I would guess that happens fairly often. And the information that is gathered in those investigatory office conferences is investigatory information. So I think sometimes it might come to you. So if there was information that we got in an investigatory office conference that we're using in a site, then you may be aware of that. Otherwise, you may not, and it's just a tool. It's one way that we get information to get the evidence to bring to the board, if that makes sense.
It does.
So,
Thanks.
but
and I'll just,
yeah, but I guess just to explain just a little further. So for example, if we're saying you didn't cooperate with the board because you didn't come to the investigatory office conference that we subpoenaed you to come to, then that would come to you in a site or a consent agreement. You would see it that way. Otherwise, you may not see that it happened in an investigatory office conference. It would just be a way to gather information.
Thank you. If I may just comment on one other thing that you said, which is to say that our deliberations need to be based on the hearing record, right? The document that's before us. Some of the cases that we see are somewhat sensational. They might be out in the news, in a newspaper, online, on TV, or things like that. And I always do my best if I come across something like that to turn away from that, to turn the channel, turn off what I'm looking at, because I don't want it to somehow be something that I voice in a deliberation, and it turns out it was not part of the hearing record. I think that's a procedural due process problem and potentially grounds for appeal. So I always do my best to close my ears, to anything that might be going on regarding a case that might not be in the hearing record, but that might be out in the public.
I think that's a very good practice, and that's a good point that you bring up. And we've had some cases where board members may have brought in additional information or tried to, and in cases where that didn't, the courts have said, if you didn't bring in the additional information, then your decision is okay. But if you're relying on information not in the record, that's definitely grounds for reversal. So I think, turning away from media reports on things that you're going to have to decide is a very good practice.
Thanks, Kim. Hi, Mr. Jackman, yes.
Ken. Hey, just following up on Dr. Feigel's comment, I wonder if we can split the difference, because I understand what Michael's saying here, but if we get the consent agreements, right, and we get them in advance, ideally, hopefully not the day before, unfortunately that happens from time to time, we get them in advance, I think we're ready as we're reading them, it sparks questions, right? So I don't want a plethora of information that's going to be in the record for every consent agreement, because some of them are like, okay, so what? But could we maybe do this? Ask for, we have questions on specific ones. Ask for the information for that. That it's going to appear in the R&R or the record. You know it by looking at it on its face. So we're not going to be prejudiced if we get it in advance, right? Because it's going to be, if we can't agree, it's going to be in the record. So why can't we get that information and kind of split the difference on this?
So I think that raises a lot of complex issues. I think we can talk about it. I think it probably depends on what you're asking for.
Well, agreed. It's good, right. But my question is, if we're asking for, additional information in general, number one, what can you give us? Number two, we may have a specific question. We can ask that too. But what's the downside to giving us just, it's targeted, right? It's not like we want to see every one of them. We just have, and it doesn't come up that often, right? It's usually, which ones you're going to nail anyways. So why not just give us the stuff that's going to appear in the R&R anyways, that isn't going to prejudice the case?
And Kim, you see, in following up what Bob said, if you take a look, and Rebecca, I was going to mention this until we got to Rebecca's session, but if you take a look at what the Attorney's General memos in this coming up tomorrow meeting, they give us a lot more information. Now, I realize it's post-site, but the issue is still the same. They're going to end up in court if we say, no, we're not going to take that settlement. And it's the same theory that Bob and Dr. Feigl have raised, which is, you look at two memos from two separate AAGs who have to go to court to defend these, and they give us more information. And I think it is only fair, if you want the board to properly deliberate, that, telling us how long has the doctor been in practice, what is the nature of the drugs, just a more fulsome explanation. It's not going to damage the appeal process or the hearing process. If the AAGs don't have a worry about it, then I don't think that I think we're being entirely too conservative on some issues. And then you're asking us to use our fiduciary responsibility to make a decision. And again, not taking anything away from our special members. It's just that we have an independent responsibility outside of just walking in trust.
Sure.
I think that's good feedback. I think it's, things we've been talking about internally. I think it's stuff we need to keep developing. And I think there are some legal questions here that we need to look into. But I think certainly hear your concerns and want to address those concerns. For the matter of time, I think we're going to shift gears now over to Rebecca. Rebecca, you had an hour slated and you're leading us right up to the lunch break. So, I think we're fine unless anybody objects to go right up until 12:30 and just shorten our lunch from 12:30 to 1, if that's okay with everyone. Okay. So Rebecca, take the hour if you need it.
All righty. Hopefully we won't need it. Let me get to where I can share my screens. Oh, somebody has to make me a presenter.
Oh, no problem. Is your presentation ready? I'll send it over.
I'm sorry?
Is your presentation ready?
Yes.
Okay.
All right. So I'm going to talk to you today about one of our favorite topics, summary suspension. It is the most complicated and challenging thing we do in enforcement. And I think that primarily boils down to it's the cases where emotionally you want to go the fastest, but legally and resource-wise, it is the most difficult to go the fastest. So let's take a look at why those two things exist. As you've heard me say many times, we have two basic statutory requirements for every summary suspension. And those are in 473122G. So basically, you have to have the secretary and supervising member agree to two requisite legal prongs before you can go forward. We have to present them with enough information that they can determine we can prove clear and convincing evidence of a violation of your disciplinary provisions. And once they determine that, also they have to determine that the licensee's continued practice presents a danger of immediate and serious harm to the public. So we need to first talk about our burden of proof, which is clear and convincing. And as you'll see on this slide, it's a high standard, and it should be a high standard because this is a tool that is very punitive on the doctor and needs to be used responsibly. So in our regular administrative hearings, our burden of proof is a preponderance. And preponderance is basically just more likely than not. Basically, you get over 50%, you've got a preponderance. But what we really have to use in real life is the next highest standard, which is we call RPS, reliable, probative, and substantial. And the reason we really live in RPS instead of preponderance is because when your case is appealed to the court by the doctor, to survive the appeal, you have to have RPS. So that, of course, is the hurdle we always hit. So in simple terms, reliable evidence is dependable and trustworthy. Probative evidence tends to prove what's at question, and it has to be scale, which I know frustrates doctors who are scientific minded and frustrates us too as lawyers, frankly. So then we have clear and convincing. That's what you need for a summary suspension. And clear and convincing is more than RPS, but not quite as much as beyond a reasonable doubt. So, to send somebody to prison, to convict them criminally, you have to have beyond a reasonable doubt. So we're close to that, but not quite as high. But it is a high burden for us. And that is why it is a difficult legal hurdle for us to get over to do a summary suspension. So these next few slides, we did provide you with the PDF handout of this entire flow chart of factors for and against summary suspension, because it is a little bit hard to read these slides. But if you want to spend, some night you're having a nice cup of coffee or a glass of wine, some studying this beautiful chart, that will be an evening that I'm sure you will find memorable. But this is basically the grid that we live in when we're trying to figure out whether or not we can get over the hurdle for a summary suspension. And again, no black and white issues here, and none of these is really the deciding factor. It's just the totality of everything and whether or not you think you can get over that threshold. So the first thing that we will look at is what is the licensee's current status here in Ohio. If someone's license is active, that means they have renewed it and they are current right now to a period till their expiration. Once they hit their expiration date, they're expired, and technically they're not really holding an active license, but because of some case law we have, they basically have a 2-year window where they can automatically renew online and kind of cure that. And that is called an expired license, but not yet lapsed. Once they're past that 2-year window, that is when they are lapsed and they cannot practice in any way, shape, or form unless it's unlicensed practice, and they cannot automatically renew their license. They'd have to apply for restoration. So the first thing we look at as our threshold decision is what is their license status. If it's active, that weighs in favor of doing a summary suspension because they're fully authorized to practice. If it's expired, it technically weighs against because they're not legally authorized, but in practicality, they could be practicing and that might swing you the other way. If they're lapsed, you cannot do a summary suspension because there is no license for you to summarily suspend. The other thing we'll look at is, do we know whether or not they're retired? Many physicians who retire from active practice still maintain an active license. So that again is kind of where you're straddling a painful fence. Technically, legally, they might be fully authorized to practice, but factually and practically, you might have actual information that you know they're not. And so that becomes a difficult issue for the secretary and supervising member in trying to figure out, well, in this particular aspect, where do they fall? One of the other things we'll look at in addition to that is, are they actively practicing here? So many physicians have an active Ohio license, sometimes because they're practicing here, sometimes because they graduated from medical school here and this is kind of their primary license, but they might actually be in another state and have a license there and be working there. So even though they technically, legally are authorized to be practicing here, if you have actual factual knowledge that they're not here, that's something else you have to factor in as to whether or not you think you can meet that burden for a summary suspension. Where it gets challenging for us is where we don't always know if they're actually practicing here. And it's, it seems like it'd be simple to find that out, but sometimes it's not. Sometimes you get bad doctors who are kind of hopscotching around from location to location, and you can't figure out if they're practicing. Sometimes they're not practicing in Ohio as far as you can tell. There might not be anything on ORS indicating they're prescribing to anybody, but they might be right on the Ohio-Pennsylvania border or the Ohio-Indiana border. And so you might have concern that they are actually treating Ohio patients. So again, that's another gray area we will look at with the secretary and supervising member. We will also look at whether or not they have been restricted from practice. Sometimes if there's criminal actions going on, part of the bond is they're not allowed to practice medicine. So again, while that's good that it's being addressed, it's bad for the ability of doing a summary suspension because you cannot get over that second prong of immediate and serious harm if they're actually not allowed to practice. So in many of the cases where I understand why board members have the emotional reaction they do of this seems super bad, why isn't this a summary suspension? Most of the time, there's some underlying thing that's stopping us from being able to meet those hurdles. Something like this. The nature of the violation is a very significant pebble in our accumulation of how many pebbles do we have on the scale. We have many cases where someone has technically violated some disciplinary provision, but it isn't serious enough to warrant a summary suspension. In other cases, the nature of the violation, it's a slam dunk. You want to summarily suspend somebody. What's interesting here, and again, kind of counterintuitive when you see the information in the site, are the prescribing cases. The worse the prescribing is, probably the better chance that we've been working with the DEA and that the DEA would have gone out and gotten someone to sign a surrender of their DEA certificate. Again, really great for public protection because what we want to do is stop the prescribing as soon as possible, but bad for us as a board because you cannot show immediate and serious harm, risk of harm, based on someone's prescribing if the federal government has now stopped them from being able to prescribe. So that is probably the most common reason you're not seeing a summary suspension in some of those prescribing cases that look criminal. in prescribing cases where it just looks.
But
Yes.
Rebecca, sorry, why can't we know that? Why can't we be told the DEA took action?
You will know when we issue the site based on the DEA surrender, if we do. But sometimes we use that DEA surrender as leverage to get them to sign one of those agree to be suspended until your criminal case happens, those non-cooperation agreements. And sometimes in securing those agreements, we agree not to go forward on the DEA surrender if they do the agreement to be suspended, because that's better for you. If you do the site on the DEA surrender, again, you can't do the summary suspension, so they're going to keep practicing while they work through the hearing unit, which is going to take, at a minimum, many months, versus if you can get the consent agreement where they agree to be voluntarily suspended, that can take effect now and will stay in effect until that criminal case is resolved, even if that criminal case takes 2 or 3 or 4 years. So sometimes it is a trade-off, and that is why you will sometimes see it and sometimes not. Does that answer your question?
Thank you.
Rebecca, it
Yeah.
may not be, it may not be now, it may be a moment later that you have to answer this. The involvement in locum tenens physicians in this whole process is how do we catch them? How do we assess them? And
yeah,
excellent. We have a lot of
question. They in my anecdotal opinion, are always a concern. There are, many good physicians who work locum tenens and are fine, but it's one of those things, just kind of experience has taught us in enforcement, makes us scrutinize things more closely. Sometimes people are doing those locum tenens because they're trying to avoid detection of something. We see it, with impairment. We see it sometimes in sex cases. It's kind of a red flag for us, honestly, and it does make it more challenging to collect information, because typically when they're working locum tenens, the hospital's doing it through some contractual basis with some physician recruiting or physician supplying business. And so when the doctor gets into trouble at the hospital will just call the contracting agency and say, don't send Dr. Smith back anymore. And they're like, oh, check, we got rid of Dr. Smith. But it makes it much harder for us to track down what we need to know, because they're kind of all over the place and we don't always know where they've been.
But if you're in locum tenens, you still have to have your degree, your license for the state in which you're practicing, right?
Correct. Yes, it just practically makes it much more difficult to collect the information and evidence we need to summarily suspend them.
Thank you.
You're welcome. So,
question?
Yes.
Yeah, I just have one question, Rebecca, based on the example on the DEA.
Yes.
I've heard state boards say when the DEA gets involved, everything slows down because they're not, unlike a medical board, they don't have physicians or whatever, and they're all like putzing around here and people are dying. And some states have just said, we're not going to wait any longer. We're moving on these guys because you guys are just jacking it up, waiting for your prosecutorial group to get involved. Is that what we're having? Because that's a concern I would have, is we're sitting here waiting for the DA to come to town. People are dying and they're all willing, willy-nilly try and get their case up. Where's that put us? And should we take action?
Yeah, that's a good question. And James Roach, actually, as the head of investigations, may want to pop in here when I'm done and add some more information, because that's more his wheelhouse. But I would say, in general, my experience with the DEA has been positive. They do sometimes slow things down. If they're working on a huge undercover, sting operation, they may say to us, we don't want you to go out and talk to Dr. Smith, because it's, that's going to give them the heads up that we're on to them. So we do try to be cooperative with them. We do not try to let them dictate what we're doing. It is a balancing act, like I think all of our relationships with law enforcement are. We have had a couple of cases in the years I've been here where the DEA or other federal prosecutorial arms have actually threatened to charge us with obstruction of justice if we went forward when they told us to wait. So I think my answer is we try to cooperate with them. I think it does sometimes slow things down a little bit. And we try to make a decision with the secretary and supervising member about the benefits and risks of working and what makes sense to get to where we all want to end up. James, anything you want to add?
Sure. I mean, I think it's an excellent question. I mean, our relationships with our law enforcement agencies has certainly continued to improve. We've got very strong relationships with our law enforcement agencies. We are certainly trying to take into consideration how long it's going to take for the investigation, and also understanding it's not just this investigation with us, but all the other investigations that will come as well, so that we want to make sure we have those good relationships so we can share information. So it might just be this particular instance, we have the case that's maybe going a little slower than we would like, and we have information on it, but next time it could very well be that we're beholden to the DEA because they've executed a search warrant, they have the patient charts, they have things that we don't know. So it's certainly a balancing effect on both of those things. One of the things we often have our conversations with the DEA is, okay, maybe you're just concerned about prescribing, but there's other ethical issues that we could still proceed on, that we can interview the doctor, that we can take action on. So we're really, and to the extent possible, also trying to parse out what are the things that the DEA or whoever it might be, whether it's local law enforcement, statewide level, what do we sort of set on the side to work with our law enforcement partners? Where can we move on administratively because it's not within their jurisdiction quite as much?
Okay, thanks.
All right. So another big factor for us is how long has it been since the underlying events occurred? And this is another situation where, as board members, you will sometimes see information, and I think your natural question is, what took us so long? Most of the time, or at least a good percentage of the time, we don't know about things when they're happening the moment they happen. So a lot of what we find out happens when people renew their licenses, and that only happens every 2 years. So if someone's answering yes to one of those questions, I got criminally convicted of something, I, am aware of an investigation against me for some reason, we may not know about that until, 23, 24 months after it happens, depending on where their renewal cycle falls in relationship to the underlying events. There is a statute that says prosecutors are supposed to notify the medical board when our licensees are convicted of certain crimes, but most of them don't do it or don't know about it. It is rarely reported when it happens. The other thing that happens, and is kind of in that old Angerman case that I gave you, is even if someone discloses something on a renewal, we will, send them a letter. Hey, you said you had a hospital action. What was that about? It takes some time for us to investigate that. If it's a minimal standards issue, it takes some time. You're basically building a multi-patient malpractice case. So you've got to find an expert. It can take a significant amount of time to develop those. And then by the time you actually have met the critical mass for clear and convincing evidence of a violation, you're out a long distance from the underlying timeline, and that can be a problem in being able to summarily suspend as well. So one of the things we'll look at once we get through all kind of those preliminary hurdles is kind of a 10,000 foot view, the global look of how strong do we feel our evidence is. And a lot of this rests on kind of your experience and the feedback you've gotten from the courts and from the hearing unit and from you as board members about what's important, how other cases have been handled that have come before. But it generally falls into some of those buckets that I put on your slide. So we'll look at, if it's victims are involved, we will look at the credibility of our victims, the number of our victims. Do our victims tell similar stories? That weighs in favor of summarily suspending people. If you have three victims who don't know each other, and they're all saying the same type of event happened to me at the doctor's office. That bolsters each victim's credibility. On the other hand, sometimes you get situations where you have a victim who is credible, but then they tell someone, a sister, a friend, and that person will say, oh yeah, that happened to me too, but I never said anything. So they may be credible, and we assume that they are credible, but we have to also recognize when your victims are too much intertwined, particularly if there's a sister relationship, friend relationship, the other side's going to attack that they've kind of been in cahoots to cook up their story. So that's something else we will look at. We will look at someone's prior complaint history and board history. So if someone has been disciplined, formally disciplined, public action by our board for an offense before, and then you see that offense again, that is very compelling information that weighs in favor of a summary suspension, because you already have, one or two or three adjudicated cases where you've proven that person's conduct that's consistent. So that is a great thing for us when we want to do a summary suspension. We will also look at what, physical evidence do we have? Do we have audio recordings of the interview with what all the witnesses have said? Can we show that the doctor's been inconsistent in his or her story? Do we have any physical evidence of videos, text messages, phone messages, Facebook messages, DNA, any kind of gifts or money transfers, phone records that corroborate one person's story over another? So we will look at all of those. And when you look at this slide, I know it's hard to read because there's so much information in it, but it will kind of give you an inference into the window of why these cases can be so difficult to develop. There are so many nuances. There's so much information and evidence in the weeds that you have to get through and sort through and vet before you can take it to the secretary and supervising member and say, this is what we can actually prove. The thing that's counterintuitive about summary suspension is, again, where we kind of started at the beginning. Emotionally, you want to go as fast as you can, and in your gut, this person is bad and we need to do something. Legally and intellectually, you have to get through so many hurdles to get that clear and convincing evidence before you can even take it to the secretary and supervising member, because the way the statute is set up, you have to basically have to go from zero to trial before you can start. You have to have every duck lined up, every proof issue shored up before the secretary and supervising member can legitimately say, you have proven to me that you have clear and convincing evidence. So this is the bottom part of that slide that basically just says, we take all those things we just talked about, we have a big discussion with them, with the secretary and supervising member and the AGs, and we distill it down into making an evaluation of our totality of evidence. And we have to ask the secretary and supervising member two questions. We ask them whether or not they find that there's clear and convincing evidence of a violation, and they both have to say yes. If one says yes and one says no, you can't do a summary suspension. They both have to say yes. Once they say yes to that issue, you then can go on and ask them the second legal prong, which is, do they find that the person's continued practice creates an immediate and serious risk of harm to the public? And again, they both have to say yes.
Rebecca?
Yes.
Is there, how shall I say, is the question of whether or not there's clear and convincing evidence conflated with the question of can we win?
Well, interesting question. I would say, in my mind, any case where you have clear and convincing evidence, I assume we're going to win. Because if you have clear and convincing evidence in an environment where you only have to have preponderance or reliable, probative, and substantial, you should win. It's not always a slam dunk. Sometimes you might have clear and convincing evidence at the time the secretary and supervising member say yes, and then before you get to the hearing, something unexpected happens. Maybe a key witness becomes unavailable or dies. Maybe, something that seemed to be true and had been vetted, someone recants. So we have had isolated incidents where a summary suspension has kind of fallen apart, but it's rare. We do a good job of making sure we are solid, and I think if you're that solid when you start, you're going to assume you're going to shoot out on the winning side.
Thanks.
So what happens next?
I have a question too related to that.
Yes.
You said that if the secretary and supervising member disagree, then it just comes. So one says that it should be a summary suspension, and one says that it should just be a cite. That it comes to us as a cite, and then we as a board, by a majority vote, are supposed to decide about the cite. And we're voting on the cite without ever knowing anything about a summary suspension potentially being necessary. There's no rule that it has to be unanimous. Yet with the supervising member and the secretary, it has to be unanimous. So again, they're making decisions for us as a board fiduciarily, and we're being held to those decisions without any knowledge of that issue even being an issue. To me, from a fiduciary responsibility, it just does not feel good to me, and I can't believe it was the way the system was designed. If that's the system, we should let them issue the cites, and we should never ratify the cites, because I'd be curious how many times a cite that was being proposed to be issued wasn't issued. I'd love to know the answer to that. I bet you it's never. So yes. It's just a vote that's a formality without any of the information.
Yes,
I don't like that as a board member.
I can probably give you some information that hopefully would be helpful. So in my mind, the secretary and supervising member are not making a decision for the board. The secretary as to whether or not to discipline. The secretary and supervising member are making a decision on, can you discipline now versus can you discipline later after the hearing process. So if you do a summary suspension, what's unique about it is you're taking an action now and you're taking an action later. I actually have a slide on this in a little bit. So they're not saying to the board, don't discipline. They're just saying, we don't think you've gotten over that extra high hurdle to be able to discipline now. The issue of whether or not a cite has not been issued by the board, there has been one in the time I've been here that the board did not issue. In the old days, before I came here, there was a time when enforcement just sent the citations based on the recommendation of the secretary and supervising member. There's not a legal requirement for a regular cite to be issued by the board. The reason we do that is because practically what happened before was the board with the secretary and supervising member would be issuing disciplinary cites, and then your board members would not even know what had been issued or had any input or seen anything in advance, and people would ask them, hey, what about that? Or they wouldn't know what was going on. So I think it's a good practice legally, but sending the regular cites to the board is really a courtesy that we've built into our process, and also so that we can let the board members see what we're doing to make sure there isn't anything that you don't want to go forward. Because there has been one time where they said, no, we don't want to issue this. So let's look at what happens next. So if both your prongs are not satisfied, you have three options. You can do a regular citation. That's what we just talked about. You can try to get more evidence to do a summary suspension later. So if, for example, we had a case we were trying to do, a lot of times whether or not you can get that summary suspension pulled together depends on how long you have till the next board meeting. So an issue that comes up the day after, the Thursday after a board meeting, has much better chance of getting summarily suspended the following month than one that comes up 2 days before the next board meeting. Just logistically, you can't get your information together. So we will have discussions with the secretary and supervising member at times to say, how bad do we think this is going to be based on the preliminary information we have? And is it smarter to work an extra month to see if we can get over that hurdle for summary suspension? Or do we think we're, for whatever reason, months away from being able to get what we need, and we ought to at least do a regular site to get it rolling? And if we can get that second bit later, we could then do a summary suspension based on that additional information. So that is something we will look at. Option 3 is try to get a settlement agreement. This is a challenge, again, in summary suspension situations, because summary suspensions by their nature are usually the worst things we're looking at. And the worse something is, the more the only settlement we're going to want is permanent surrender. And that's the hardest thing to get. So again, it's very factually specific depending on the case, what we can get, what evidence we have, but we will look at all 3 of those options and try to get you the best thing we can as fast as we can that we think is sustainable. If you get a yes and both the prongs are met, then the notice of summary suspension will come to the full board, and we need 6 of you to vote yes to issue. That's a legal requirement because, again, when you're doing a summary suspension, it's a hybrid notice. You're taking action now, stopping somebody from being able to practice, and inherent in there, you're also taking action later, which is, and when you get your hearing, we're going to figure out whether or not we're going to do something else to you.
But again, Rebecca, we're voting, just to be clear, we're voting without any of the information that really we need to make a really adjudicatory decision, a sound adjudicatory decision. So if we're truly voting on something that we should have information on, we should have the information. So this is just another area I think we really need to delve into and really look into deeply about how this is done. Not based on necessarily how it's done in the past, but what is correct.
Yes. So I think it helps to think about your decision to issue the summary suspension in kind of 2 parts, just like the summary suspension notice it is itself. Part 1 is the information contained in the summary suspension document will lay out for you what is the basis of why we think we can summarily suspend somebody right now. So that factual information will be in the notice, and that is what a board member can use to say, do I feel comfortable that based on what's in this notice, that if they go to hearing and prove all of this stuff they're saying they have is actually proven and they have it, do I feel that that is enough to support voting right now to take somebody out of practice, knowing they get an expedited hearing? Part 2 of that is then you go through the hearing, you go through all the evidentiary things, everything's vetted by the hearing examiner. You then get that more complete picture from the R&R where you get to make your second decision, which is what is the ultimate discipline I want to give to this physician or licensee. So part 1 of your summary suspension is just look at what's in the notice and ask yourself, is there enough information in this notice that I think this is serious enough that somebody should be stopped from practicing today? And then part 2 is once I get the hearing and everything else is vetted and everybody gets to do their testimony and their cross-exam and all the experts testify and all the documents get introduced and accepted by the hearing examiner, then I will have more information to make a fully informed decision about, do I want to revoke you? Do I want to suspend you? Do I want you to take courses? So it's kind of think of it in that way. It's a 2-step process. So here's what happens after you vote to issue a summary suspension. We send the notice by certified mail. That's required by 119. And we also send it by personal delivery if it's somebody who's here in Ohio. We send it by personal delivery for more of a practical issue, which is legally your summary suspension is effective when you issue it. But if the person doesn't know they're summarily suspended, even though they're not legally authorized to practice, they're going to come in later and say, well, you didn't tell me I was summarily suspended, so how should I know? So we do that extra step of personally serving it on them to say, hey, stop practicing. The trade-off in the statute is if you get the power to take away someone's ability to practice without giving them due process up front, you have to give them an expedited hearing if they ask for it. So in a regular citation, they have 30 days from the date of mailing to request a hearing, and the hearing gets scheduled when it, fits the hearing unit's schedule. It's going to be months down the road. With a summary suspension, we do not have that option. You have to be ready to present your case 7 to 15 days after the doctor asks for a hearing. So again, kind of goes back to why these are very challenging. If you summarily suspended someone tomorrow at your board meeting and they got personally served with it on Thursday, they could request a hearing on Thursday and you'd have to go to hearing the following Thursday or the week after that, unless both the doctor and the secretary and supervising member agreed to a continuance. So again, another reason you have to have everything in a row. There's some special constitutional property interests in people being able to use their license. That really gives us a high hurdle here. Also unique to
Rebecca,
yes.
forgive me. You think that 7 to 15 days is a reasonable hurdle? In other words, do you feel like that's fair, or do you feel like what's more fair is maybe 15 to 30 days? Is that something that we would be right to advocate for in the legislature, as opposed to extending that, because that 7 to 15 is just too short?
Yeah, I don't think I could give an objective opinion about what I think is fair. And I think what's more important is what I think is fair doesn't matter. The constitutional issue here is, people have worked hard to get their medical licenses and the other licenses that come through this board, and they have a right to earn a living. And it is incredibly disruptive. I mean, you can imagine if a medical board investigator showed up in your office tomorrow and said, stop practicing, how horribly disruptive that would be to your practice and financially and to your reputation. So, I think it's right that we have that high hurdle. You don't want boards willy-nilly, summarily suspending everybody for everything because it's just too much power that's too easily abused. In my mind, the way the statute is set up, it works. If you have the clear and convincing evidence, then you've done your job and you're ready to go in 7 days. Because if you have to have that clear and convincing evidence up front to be able to do it, I mean, you could go to hearing in 2 days. You've got it. You're ready. So I don't think it's a limitation other than the fact that it, just rightfully so for balancing the interest between licensees and the board, you have to get over those big hurdles. So once you've had your hearing, the board has to issue its final order within 75 days, or the summary suspension automatically dissolves by operation of law. So this also puts a lot of pressure on our hearing unit and on our board members, frankly, because it all has to move at lightning speed. Another unique aspect of the legal issues around summary suspension is that the appeal process is different. So when you have a regular site, you go to hearing, you have your report and recommendation, it goes to the board, you issue your order, and the order takes effect. When it's mailed, then the person can appeal it to the court, and the court can give them a stay if they ask for a stay. Most of the time they do give them a stay unless it's, something where you really can demonstrate patient harm. Summary suspension is weird. So they cannot appeal the merits of the case until the board issues its final order because it's not really ripe yet. You haven't had the hearing about the merits, but they can appeal on whether or not the board has satisfied the proper legal steps. So someone could go to court and they could say, we don't think the secretary and supervising member actually answered both of those questions. Prove to us that they did. Or we don't think you gave the secretary and supervising member all the information that you said you gave them. Showed us that you did. So everything has to be absolutely right, because the last thing you ever want is you do a summary suspension on somebody and then you have to retract it. That is the worst possible position for the board, because you pretty much publicly said, this person's dangerous and oops, we didn't do it right, so here's your license back. Hence the titles of my next slides, one chance to get it right. They are unique. Again, it's a two-step process. You're doing action now, which is I order you to stop practicing, and action later. I notice you that I'm going to give you final disciplinary action after you get your regular hearing. They are intertwined in a way that you really can't separate them, because all the evidence you're using to support the threshold for summary suspension is the same evidence legally and factually you're using for your final order. The 10th district, which is our appellate court, has said that summary suspension only exists until the board issues its final order, and then it's superseded. So again, everything is just inexplicably intertwined. And here again is my slide back to our previous comments about courts are very sensitive to the potential abuse of summary suspension power. It is an extremely powerful tool. It's good to have. We have to be very responsible in how we use it so as not to get a smackdown. So the US Supreme Court basically has this general kind of three-step analysis, which frankly I think is generic and not super helpful. It's basically the importance and interest that everybody has in protecting the public versus your license and your ability to practice. What is the risk the board's going to get it wrong? That's one of the factors they look at. And the administrative burden. How hard is it for us as a board to get over the hurdles they've asked us? And is that reasonable in exchange for us saying we should be able to stop someone before we give them a hearing? This is my slide on, again, just the technical issues being so important. It is just critical that we do everything exactly right, follow those prongs, document everything. If they go and do an appeal on the procedural aspect and we cannot demonstrate we have jumped through all those hoops appropriately, we will be done. So here's some general case law we pulled up that I thought might be helpful, just kind of having your frame of reference. The court can't hold up the agency's order if it's based on findings that are broader than the charges set forth in the notice. So this, again, like everything we do, is a balancing act. In your notice, less is generally more. You have to prove every sentence, every word that's in your notice. So when we're writing citations, we are trying to boil them down to their core issues, because for proof purposes, you want to prove everything that's in your notice, and so you want that to be your core issues. You don't want to make it so detailed that if you say you gave someone 500 milligram dose of something and you get to hearing and they say, oh no, it was only 350 milligrams, then your notice is wrong. You haven't proven that. And it seems like it shouldn't matter, but it does. You know, lawyers live and die by our words. So we are always balancing in the notices how much is enough. You want it to be sufficiently detailed that it's communicating what is at issue, but you don't want it to be so detailed that you're setting a trap for yourself to fall into innocently getting something wrong. The other cases I put in here are just kind of timing issues, which again are kind of amorphous and not black and white. There are cases where the courts have said you waited too long to do a summary suspension, but they've never really said how long is too long. It's all very factually specific. This is the one that sticks in my craw, and I gave you a handout on. It's an old one from 1989, right after the board got our current summary suspension notice. This particular opinion, written by David Feiss, our former deputy director when he was a judge, who at that time said, we waited too long. When we waited about a year, I think it was actually 10 months, after we had knowledge of a licensee's practice violations, that we couldn't summarily suspend. And I gave you that case because I personally think they got that wrong, but it's it's what we live with. And it's a good example of, we found out about what happened months after it actually happened. So I think we were reasonably timely, but the underlying events looked old by the time we got to the summary suspension because of the time that elapsed before we were notified. Any questions? And it's 12:15.
No?
Rebecca,
Yes.
I just wanted to comment that many times we want to do a summary suspension as the secretary and supervising member, but we can't answer yes to both prongs. And things seem to be very bad, but we can't do that. And then it comes to the board as a site, and the board is concerned that we should have done a summary suspension. And that's happened many times, that why didn't we do a summary suspension? So it kind of goes both ways, and you explained everything beautifully.
Well, thank you. Yeah, I understand everybody's perspective on this. And reasonable minds can differ. You could have a secretary and supervising member who thinks something is clear and convincing, and if you had a different secretary and supervising member, might not think it was clear and convincing. It all kind of funnels into our system of checks and balances, and that the board appoints the secretary and supervising member. The secretary and supervising member have certain parts of the process they do. The board has certain parts they do. One of the things I would say is, when you see a site that gives you heartburn and you wish it was a summary suspension, chances are better than not that we evaluated that and tried to do it and for some reason couldn't. But what I will say is, we always have the opportunity to move up to a summary suspension if we get more evidence that puts us over that critical threshold. So sometimes what we're doing is we're issuing a cite because that's what we can do at this moment, and it gives us leverage toward negotiating. It gets the hearing process going. It makes a public record, which provides some level of patient safety, and the fact that people at least know, hey, my doctor's been cited for something. And then in the background, we are still working that case to collect other evidence. And if we can get what we were missing, then we can do a summary suspension once we get that missing piece. So that's something else I'd throw out, and that might be helpful to people. In addition to thinking of it as a two-step process in the notice, in the back of your mind, you can always think, if they can get more, they will do more, because we will. Anything else?
Thank you.
But Rebecca, what you just said gives me more heartburn than ever, in that if a different supervising member and secretary were doing it, they potentially might vote to do it, to give a summary suspension. The board is voting on whether to give a summary suspension or not, or whether to give a cite. That's what we're voting on, without the knowledge that we need. And so if 6 board members would look at that evidence, and or 7 board members, whatever, I guess 6, would look at that and think that there's enough evidence there to give a summary suspension, that would pass. And so it's not the secretary and supervising member who should be making that decision if the board is voting on it. If the secretary and supervising member are going to make the ultimate decision, they should be the ones voting on it, and no one else should. If we are voting on it, we're, again, as a fiduciary, we are being held to that decision without any of the knowledge that you're talking about. And so it's very uncomforting as a board member, and I keep harping on this, but I really feel strongly about that. And I think it's something we should look at. And I'm surprised the other board members don't. I mean, maybe you do. But I'd be surprised if a lot of the other board members don't feel the same angst about this as I do, because if something happens where that doctor does something and it's ever looked back upon that we should have done a summary suspension and we didn't, we're all responsible for that decision.
Yeah. No, I hear what you're saying. We all have to follow the law, and this is the structure of the law as the other thing I would say, just from my side of the fence, is, to me, it's no different than the fact that every individual board member might look at evidence and say, this warrants someone being permanently revoked, and another board member saying, no, I think they should have a 6-month suspension. I mean, every person is going to have their own individual moral compass about where they think things fall. And it doesn't matter if you're the secretary, the supervising member, or a board member. Everybody carrying out their function of the board's disciplinary process is using their own judgment about what they think we've proven and how much weight that carries. So, I don't expect all the board members to agree. And, that's why we have deliberation and you discuss things. I think it's the same for the secretary and supervising member. I will say, I don't know if this will make you feel better or not. I mean, I've been here a long time. I cannot recall a single time where staff has said to the secretary and supervising member of any secretary and supervising member through the years, we think this should be a summary suspension where it has not been approved. They have, in every case where we have presented to them what we feel is clear and convincing evidence, a summary suspension has been issued in my lifetime here at the board of 19 years. Anybody else? All right, thank you very much.
Great.
Thanks, Rebecca.
Okay, so we are on track. We are going to take a break until 1 o'clock for lunch. Does anybody have any questions about that? Otherwise, we'll see you all back here at 1 o'clock. All right, thank you.
Thank you.
Everything.
Okay, and the live stream has begun.
All right, welcome back, everyone. Everybody can see my screen okay? Get a couple of nods on that. Okay, great. So we're going to move on to our next agenda item. We have about 45 minutes slated for this discussion, and then we'll wrap up with a training from DAS. So next up, we're going to talk about our FSMB report. If you'll remember from the summer, I think we shared that with you in August, at the August meeting. We received that message, or we received that report at the July-ish, shared that out with you in August. And this FSMB report was requested from us to the Federation of State Medical Boards as one of the steps from the Strauss Working Group recommendations. The working group had recommended that we audit our complaint process, essentially. And we decided to start with the Federation of State Medical Boards, providing us some national expertise into that, into an audit of our complaint process. We, in the future, are going to break that down even further and have OBM do some internal audits on the more granular steps within our process. But the result that we received from FSMB was, a rather robust report about many steps in the process of how we handle complaints. And some of that was relative to our board structure. And so what I would like to do today is focus on that, the board structure. When we initially looked at the report and provided that to you, we broke the steps up into action items that were colored green, red, yellow, and orange. Our green items were those items that we thought all systems a go. We think that we can accomplish these, don't need much discussion. In fact, a lot of those were already underway. Of the green items today, there were 30 green action items, and I think we're underway with about half of those already or have completed some of those. We will be putting all of this together into one big master project plan like we did the Strauss Working Group. And we sort of wanted to get through that. And now that we're nearing completion of that, we'll be moving into this second big project. Of the yellow items, we still need to have more discussion. What I want to talk to you about today are some of those items that we labeled as orange in that initial action plan. And those orange items are really items that are significant changes, that would be significant changes for our board, and that are really relative to how you all work together and how you interact with us as staff. So what I want to talk today about are the 5 recommendations that we've sort of summarized here. I would say that you wouldn't find these exactly like this in the FSMB report. We've streamlined some of these because some of the recommendations were redundant. We found them in different parts of the report. I mean, as happens when you have a really robust report like that. So we've streamlined the board categories into these 5 different topical areas. The first is relative to term limits and nominations of board members. The second is about committees. The third is about our licensure committee specifically. The fourth is about that role of the secretary and supervising member. FSMB has recommended that we recharacterize that as an investigations committee. And then the fifth is about a quality assurance committee. So as we walk through each of these, some of these we have staff recommendations on to take action. Some of these we have staff recommendations on that we need further discussion. I think at the outset, it's important to recognize that these are all, again, pretty significant changes from the way we do business. And the recommendations from FSMB were timely. I think that they were insightful, and I think again they merit some discussion amongst us. And this is really, I think, this board's opportunity to think about how we adapt the board to the future of all boards, right? Regardless of who is sitting on the board, I think this board has the unique opportunity to say, how should the board function for this next chapter of the board's history? Much like we talked about this morning with the history coming out of the 80s and into the 90s on how that secretary and supervising member role was defined. So you are all empowered for this next chapter of the board's history. The first presentation, or the first recommendation, is relative to term limits and the election process for board members. Something that you're going to see throughout these FSMB recommendations is their recommendation on more board involvement, having more board members participate in different processes throughout. I think that's really where this push for term limits is coming from. Right now, we do elect a president and a vice president. We elect a president and a secretary and supervising member every year. What we do for the presidential role is we typically follow a seniority system. What we do for the secretary and supervising member role, I've only had 1 year of experience with this, but we continued the existing secretary and supervising member. So, you can, the recommendations from FSMB talked about how these positions should be elected annually on skill and merit and not seniority alone. That's relative specifically to the presidential role. And then they outlined some of the benefits of term limits in the election process. Again, sort of the board involvement, the board engagement, I guess, is how I would characterize it. Staggering terms would help with a sense of continuity, allowing for rotation of committee assignments as different members take on different roles. And then I think too, one of the things they highlighted was really providing that opportunity to work in different capacities and engage dynamically in different ways. So, this is actually an older presentation. I pulled the wrong one. So what we're recommending, so disregard what this, I'm missing a word in here, I'm sorry. So what we're recommending with relative to the FSMB recommendations on elections of the president specifically and term limits, we do not recommend instituting term limits for officers. We've had some internal staff discussion on this, and we think that, the process in and of itself is you have the opportunity to naturally term limit people by undergoing an election. We do an election for the president, secretary, and the supervising member. So you have that opportunity to sunset positions as a board. So we do not recommend implementing that. We also know it's very hard with the secretary and supervising member, one, to find folks who have the time commitment to be able to do that, and two, the knowledge and skill to be able to do that. But relative to the nomination for an election for president, I've heard split conversations from you as board members, frankly. I've heard some board members indicate that they would like to explore the idea of not following a seniority system every year for president. I've heard others of you say that it's very important to you that we follow the seniority system and that the seniority system itself has merit. As an executive director, I don't know that I have a recommendation. I think that it really is something that as a board, I think that we need to have that discussion on the pros and cons of doing the nomination or on following that seniority system. And what I would propose that we do before we have the December meeting is that we do actually have that discussion scheduled at the November board meeting, and that we have you all talk through what you think your pros and cons are before we enter into the next cycle for the board president. And if anybody has any thoughts on that, that would be our recommendation, that we put that on the November board agenda.
Well, so you'd rather us discuss it in November than right now?
I am fine if you want to talk about it now. Yeah, I'm fine. I think that, we can either talk about it now and decide, or we can talk about it in November. But if you'd like to, go ahead.
I guess I had a couple thoughts about it, if everybody's okay with that. Ironically, the FSMB recommendation that elections should be based on skill and merit are contrary to the idea of promoting board member experience and education, because it is, I think, those board members who are more competitive that are going to run for those positions, and the board members who are less competitive will not. I think that everyone on the board has the baseline skill and merit necessary to be vice president or president. So I'm concerned that some board members will be robbed of that opportunity because they're not inherently competitive enough to run for an office, and then they miss that valuable educational piece, which would add to their skill set as board members. And I also think we have a very collegial board. My concern is that injecting politics into the election of officers, would diminish the collegiality and make it harder for us to work together. I have seen for myself how hurt people can be when they lose elections. And I would personally want to avoid that and continue the seniority system that we have currently. I don't think we've ever had a problem with it. And then just in terms of the other points that you made, in terms of avoiding things like stagnation and tiredness and boredom and loss of commitment, board members can decline to run for a position. Board member doesn't have to run. So if a board member is in a position for a long time, it's because the board member volunteers to do it on a regular basis. The terms, of course, are only 1 year long. So for president and vice president, there's built-in turnover. We go back to the end of the line again, and someone else takes over after the year is up. It's really only for the secretary and supervising member positions, I think, that there's that concern about stagnation and tiredness and burnout. But again, they have the option of declining to run if they've had enough. So I just wanted to give my 2 cents. Thanks. Yes, Mr. Jackman. Oh, sorry.
I totally agree with everything you said. I mean, you couldn't have said it any better. I agree with the collegiality part. Whenever you see elections, they always get into hurt feelings, and that's something we really don't need. And second, seniority makes sense. You've been around the block, you've seen the things go. I mean, it makes total sense, especially if we have turnover on the board. I don't see any reason to change this, and honestly, I think it would be a disservice to change it.
Thank you. Ms. Montgomery.
The trend over the last few years has been, particularly in universities where this was next person up in a seniority system, has been to move away from that and have the vote based on whomever wants to run and whoever garners enough votes to get that. I do think we have an exceptional board and exceptionally collegial and mission oriented. I don't feel that strongly one way or another. I do feel strongly that the secretary and supervising member, if we were to say tomorrow, we're not going to elect Dr. Rothermel or Dr. Safran, what we're doing is we're basically they've worked very well. We can make this argument later, but remember, if we were to change them, not because they asked to be changed, but because we said, well, let's give somebody else the excuse. You've basically made them now sit on a board, and they're going to have a huge percentage of the work that they've done disqualify them from being an active member on the board for some time. And I just think we have to remember that. I do appreciate that the FSMB is trying to get more board participation. I think we can do that if the board wants to not use a seniority system. Is that we spread out. We do the work in the committees. It's one of the things as a board chair at BGSU we do is we work people through chairmanships on the board so that by the time their term, should they become president of the board, they've had experiences in most committees, either as chair or as a member of that committee. So that's the only observation I would make. Otherwise, I think Dr. Schottenstein, your comments are well taken. If this were not the board it is that I'm sitting on now, I would recommend that we not have seniority, but I don't see that in this board, and it's thus far, you know, I realize it's dependent on personalities, but so far I think we've been, in my opinion, I think I'm very lucky to be on this board. We've got wonderful people who are bright and engaged.
Thank you, Ms. Montgomery. Dr. Sohn.
Yes, hi, thank you. It sounds like we have consensus based on the opinions I've heard. I do want to say I'm not against having nominations and elections of board officers. You know, I think if someone's really motivated and wants to lead, they clearly, and win an election, that seems like a fair process, and they clearly would have leadership opportunities to do that. I really, for lack of sounding callous, I really don't care if someone's feelings are hurt because they didn't get elected president of the State Medical Board of Ohio. I think you just need to deal with that internally. And if you can't handle that adversity, I don't know if you're fit to do a lot of things, actually. I think that if you were to have open elections, it might be smart to institute a term limit for president for 1 year over a 5-year term, just to prevent someone who is, say, very articulate and gifted at winning elections and influencing people from winning over and over again. But I'm also fine with the current system. I just wanted to make it noted that I'm fine with free and open elections as well if we decide to do that. But if we do that, I suggest a 1-year term limit for president.
Thank you for your thoughtful comments. Is there further discussion?
Okay, great.
Thank you all.
Thank you. All right, so I think that Ms. Montgomery created a nice segue for us into the next group of recommendations from the FSMB was relative to our committee structure. Here on the presentation, we have 10 advisory councils and committees identified. We also have an ad hoc telehealth committee that is currently operating, and predating me, we had an ad hoc ICD-10 committee that we are looking to restart. So there are 2 additional committees that we will be adding in, and FSMB, without specificity, has recommended that we reorganize or consolidate some of these committees. From a recommendation standpoint, I think where we are right now, we are very close to sunsetting the Sexual Misconduct Committee. The work of the Strauss Working Group is nearly complete. We have, you'll receive a further update tomorrow at the board meeting, but that work is nearly done. And so I think that is one that will come off of our calendar. I have heard from a couple of different board members that the policy committee sometimes feels rushed because of the time that we've set on it and the need to start the board meeting. I do think some of that is maybe exacerbated because we have to be right on time on the Zoom meetings for our respondents who we have on the Zoom call. So that we might be feeling a little more pressure on the policy committee timing right now, just based on our Zoom format. But again, I do think, we normally slate an hour. We tend to always go over on policy committee, and we're definitely having more robust legislative discussions at policy. So we would recommend extending that meeting to an hour and a half, and of course, shortening it where we don't need that much time on things. With respect to the compliance committee, that committee has met only a few times since I have been here as executive director. I really think that we have a lot of what I would call, kind of policy type work that we need to work on with respect to compliance. Some of that is relative to how we're handling our compliance and monitoring and probationers. Others, I think we need to continue to evolve this relationship that we have with OPHP. It was great hearing from them this morning and hearing sort of the structure that they have in place. And obviously, you all have some thoughts as to that structure that they have in place, operationalizing One Bite. So I think that our compliance committee, we could really dive into some of those OPHP One Bite issues as we continue to grow that program, or I would say evolve that program. And then finally, something that we haven't done, at least since I've been here, and I don't really know how you've done this before, but it's I think probably time for us to look at our list of committee members that we have on each of the committees and look at the chairmanships. And I know on some other nonprofit boards that I have sat on before, that yearly we tend to look at the committee structure and say, hey, does anybody want a change of committee, or is anybody else interested in taking on this work? So I would suggest that it's time to look at the committees. And my suggestion would be that if you would like to revisit your participation on a committee or express interest in chairing a committee, perhaps, that you let either me or Dr. Schottenstein know, so that we can review what that input from all of you and have some discussions, and then come back to all of you in November or December so that we can start the next calendar year with new or changed committee assignments.
So what would the process be?
So I think,
yep. What process do you recommend we do to?
Good question.
We could just put a question out in there out to all of us if you want to do that, or.
Right. So that's what I would recommend. I would recommend that, and I can start this with an email to all of you and say, what committees would you like to serve on? And do you have any committees that you would like to chair? And then I can call that information and then bring that back. And Dr. Schottenstein and I can kind of go through that. And if we have any conflicts, which I doubt we probably would, we can have some follow-up discussions with you all and just sort of work through what that next assignment list looks like for calendar year 21.
So I have chaired sexual misconduct, compliance, and finance, and it's been a pleasure, but I also am more than happy to take a turn and share. I think I've mentioned it before, but anybody who wants a turn, it's my pleasure, truly. Just let me know.
Okay.
Yes, Dr. Song.
Yeah, I just wanted to echo the same sentiment about policy committee. Of course, happy and fine to, if someone else wants to be involved and lead that, I'm also fine to continue it as well. But I did want to make that known for any of the other board members who want to crack at doing that. I also very much appreciate this whole segment of the retreat. Because I have felt that over time, we have accumulated a lot of committees. And when we first did this reorganization of the board, when Dr. Ram Prasad did this to consolidate to one board meeting day from two, we only had a couple of committees, and then we, add some and add some more. And then the next thing you know, we have 10. So I'm glad we're reviewing this.
Thank you so much.
Great.
Further discussion?
I have a question.
Yes, sir.
The FSMB was discussing that the secretary or supervising member not be on the licensure committee, and I'm not sure I understand the reason behind that, in the sense that we're there more to discuss with licensure issues and things of that nature, and it makes it easier for them. I would give up licensure, that's not an issue, same as Dr. Soin. I mean, I don't mind being on it, but I think it's advantageous, since we're there twice a month, to discuss issues and go through things with them where the other members aren't? That's just my question.
Well, it's a timely question because it's the next slide. So the next slide was the specific recommendation from FSMB that we reorganize our licensure committee. And part of, I'll agree with Dr. Safran on this, that I didn't quite understand the real rationale from FSMB in making this recommendation. They did mention that it would decrease the workload of investigations to sort of have this licensure committee work separate. And that licensure really is, I think maybe they misunderstood a bit of the process. And it was really maybe that there was role confusion between people who were approving licenses and then taking discipline on license. I think the step that got missed maybe in the FSMB review was that sometimes in the application process of licensure, complaints arise. And so to Dr. Safran's point, that's when it is the secretary and supervising member. If you'll think back to Kim's presentation where she gave the licensure workflow or the application workflow, the secretary and supervising member have multiple touch points in that licensure process. So I think maybe there was a lack of understanding, Dr. Safran, in what the licensure committee does. And really this is my next slide on this. When the FSMB talked about the role of the secretary and supervising member, they frequently referred to it as an investigations committee, right? So what we would recommend is, and you'll see this here in a second. So I'm going to table the licensure committee recommendation. Again, not fully understanding what it was that they were going to, but I don't think we can even talk about that recommendation until we talk about the investigations committee recommendation. So the investigations committee recommendation from FSMB is really what I would say is a supplement to our current secretary and supervising member role. I wouldn't go so far as to say it's an overhaul because they did not indicate that the way we handle complaints should be overhauled. The concern noted from FSMB was that the lack of an additional public member in the secretary and supervising member process. And again, some of these recommendations for FSMB were a little redundant. At the beginning part of the report, we saw from them that the committee, that this proposed investigations committee, should investigate each complaint and recommend the disposition to the board. So what the secretary and supervising member do now. Later in the sexual misconduct portion of the report, they recommended that this investigations committee be involved in the closure there. Now, if we did the first bullet point, that takes care of the second and third bullet points because sexual misconduct complaints are just really a subset of all of our complaint handling. So where they've recommended that cases go from investigation to immediate close, the investigations committee would be involved, or when a sexual misconduct case goes through enforcement, it shouldn't go to an internal committee, but it should go to the investigations committee. So we're working on some of that already with our protocol. But again, I think what's really important to note here is that this is a significant change for our board operations. And thinking back very early to this morning, I know it feels like a couple of days ago, but after the work was done in 1985, part of the work that was done was the addition of a public member. So that third public member was added for transparency, for sunshine, whatever you want to call it, into the board processes back in 1985. Again, likewise, we're expanding the role of the public member, or FSMB is recommending we expand that role of the public member and include the public member in this secretary and supervising member secretary and supervising member review process. It's a big discussion. I don't think it's one that we can solve in a board meeting. I think all of you probably have some thought on this matter, having participated in the board. We have great tenure on this board. You're all very knowledgeable. You're all very prepared. I think I would be surprised if you all didn't have some thoughts on this. Our recommendation is that we actually create, to add to our committees, hopefully we'll restructure first and then we can create an ad hoc committee, that we create an ad hoc committee to discuss this recommendation. I would reiterate that it's this board's charge to that you make some of these changes and improvements for our future based on Strauss Working Group report, based on FSMB, just based on knowledge and national trends. What we are seeing is that more boards are putting more emphasis on having public member involvement for the sake of transparency and for the sake of that consumer eye. And I think it merits a discussion. And again, you're changing a board for the very long term. So I'd like to hear your thoughts on this recommendation.
Stephanie?
Yes.
Dr. Bechtel? Having been a supervising member and secretary, one of my concerns has always been implicit bias. When you get in a situation of sexual misconduct, and you have a patient accusing a physician of sexual misconduct and there's no witnesses. It's he said, she said, there's no witnesses, there's no evidence. Does a physician have implicit bias that thinks, oh, a physician couldn't do that, or does a physician get a second chance? That's where I think sometimes a public member, non-physician, is not going to have any implicit bias, could help weigh in on sexual misconducts, where you could community member along with a supervising member and secretary make those decisions. We try really, really hard to think very objectively about that, but implicit bias is something I have a concern about in all different levels of decision making. And I didn't know what other board members, what their thoughts were on that.
Thank you, Dr. Sloan.
Yeah, thanks. I have a strong opinion on implicit bias, not only with sexual stuff, but obviously racial issues. I've spoken to this many times privately and publicly at a board meeting. I've said that we all need to reevaluate our lives because I had some concerns about a specific case. I still do to this day. And I strongly think that we can improve on implicit bias, especially with race relations and how we hand down various types of suggested enforcement. I'm not accusing any board members of having any types of issues, but I do have some concerns about, perhaps globally when investigators review things, perhaps when they come up with reports and recommendations, perhaps, for example, not specifically saying anything, but it's a huge concern of mine. It continues to be. I think any opportunity to enhance that would be appreciated. And if it does involve a consumer member to kind of be that watchdog eye, I think that's a great idea.
Thank you so much. Mr. Jekyll.
Yeah, I don't disagree with anything you've said. I just want a clarification point on this one. Create investigations committee. Essentially, is this just augmenting the secretary and supervising member with a public member? Is that what we're talking about? Because you have these nice little committee terms, but I just want to understand what exactly this is.
That's right. That is exactly right. An augmentation, a supplement to that secretary and supervising member, not a committee. And that's statutory for us.
Okay, so the only distinction is whether they're going to be, this addition is for the sexual misconduct piece or it's for everything in. So right, that's what we're talking about.
Right, or the use in general, right? So I think the first question is, one, do we want to have the secretary and supervising member have the public member added? And two, at what stage? Is it just for sexual misconduct cases or is it for all complaints? And then I think third, based on the two type, all or sexual misconduct, at what stage is it appropriate? When we think back to those workflows of the secretary and supervising member, is it the entire process or is it at certain parts of the process? And I think that's really what we could delve into with with a committee to really kind of talk through some of those options.
Yeah, I mean, just as a counter, that's a heavy lift. I mean, we have enough problems getting the secretary and supervising member or a physician, and now we're going to get a public member to lift that order too. I'm not saying it's not a good idea. I'm just saying that's a pretty heavy lift for another person.
It is. And I think that is really where I think we have to be very deliberate when we think about at what stage that member would come in, if at all. Because again, you know, there are 1,500 subpoenas approved every year. That's a lot.
Right, and that's one less voting member from the public side on the full board too. So we shift it now so that we have one less voice on the full board for making ultimate decisions.
Correct.
Okay, that's it.
Yeah.
So having said that, though, if it's mainly to weigh in on closed cases, then these are cases that substantially would be closed and not an issue in terms of that case coming back, where a public member would have to recuse. I guess my thought, for what it's worth, is...
I guess the question was for the supervising member, and is this a difference? So it's just on closed cases, or it's on all cases? Now I'm confused.
So we don't know.
So I think that's
something we would have to work through.
All right, got it. Sorry, my understanding. Go ahead, Michael. Sorry.
No worries. Yeah, that's, I guess, part of what the committee would take a look at. I think your point's very well taken. There, you know, this needs to be feasible, right? But I also think that, you know, this ultimately gets to the whole point of why we have public members in the first place, right? It's, you know, especially if we're closing, you know, a case where there's a serious allegation, you know, I think optically it's important to have public member, you know, input as much as is feasible. Further discussion? Dr. Bechtel.
Yeah, again, I think it's a situation where, like in sexual misconduct cases, especially since we've gone through this big review and, you know, we're questioning whether or not we did the appropriate thing, in a sexual misconduct situation where the supervising member and the secretary want to close the situation, if maybe a community member could weigh in on that decision before it's officially closed. That wouldn't involve a lot of cases, but it would, again, there's a concern that we're closing sexual misconduct cases possibly inappropriately. And having a consumer member step in before a thing is officially closed would be one of the thoughts I had.
Yeah, we could always start modestly, right? Just with sexual misconduct cases for closure, and then see how that goes and potentially expand from there. Yes, Ms. Montgomery.
It seems to me that as a public member, you're looking. I'm sorry. As a public member, speaking as a public member, there are three opportunities. The committee will discuss this and I assume that Stephanie will put that on her memo to us so we can mark whether we want to be part of it or not. But you're looking at cases that are closed and we're reviewing after the fact, just generally, doing essentially a performance audit. How did we do? Is this a case where we think in a random sample, this is how we should have handled it? Looking at timing, meaning what's the length of the case and an investigation, the decisions made and all that. That's sort of the performance audit process. The case may or may not have ever gotten to us as a board. You're talking about a case that is a specific kind of content or conduct, i.e. the sexual misconduct cases. That would be one where you would maybe designate the committee. Those cases all before they're closed need to have a review. And then you're talking generally, do you need a consumer member to sit and expand the investigations committee, i.e. also reduce public participation because you can't be on can't speak on the board then, but sit to go through rounds to discuss how to handle a particular case. So I think there are 3 different opportunities. I wouldn't want to limit it to. I would want us always to be doing an audit process, just because it keeps us sort of within our curbs, an outside view, outside of physician view. Just even if it's just for the optics, and I'm not talking about it just for the optics, but for the optics, then you have an independent, you have a non-doctor review of how a particular case is in a random way, or in a methodically random way, that we can keep measuring our performance, not just by numbers, but by substance. So it seems the 3 ways that could be done, and I would not want to limit any evaluation to just a particular kind of case. And so I think the bigger question is who do you put on it, and at what point do they become? Do you want to sacrifice that the whole conversation about how you take a public member and put them in that slot, or what slots they could be recused? For example, if a public member was part of an audit committee, if you will, or whatever you want to call it, I don't want to in any way offend our special members, our supervising and secretary. I don't mean to offend in any way, but whatever we call it, if it's a closed case, completely closed, then I don't see, and decisions have been made, cases closed, moving on, and we're just doing an audit, I don't see recusal required. In the other 2 instances, it could be very problematical. If recusal could be very problematical. Anyway, that's my 2 cents.
So I think that's actually a good segue into the next slide. So again, a specific recommendation of the FSMB was that we reinstate the Quality Assurance Committee. And we've looked at that. Again, that Quality Assurance Committee was really born out of that plain dealer work. That's when it sort of, from what we can tell in history, that's when that Quality Assurance Committee came about. And what the FSMB has recommended is that we do institute some sort of, for lack of a better word, an audit process into our closed complaints, and share out those de-identified closed complaint audits to both the full board and the public. And that the committee should have public member, the Quality Assurance Committee should have public member involvement. What we would say as a recommendation is that we think that this is based on, again, feedback that we've heard from the board over the last few months, or I would say my entire tenure here, and based on the FSMB and some of what we're doing in the Strauss Working Group work with historical case review, in thinking about boards for the future, not necessarily our board that we have it today. This is something that we think is doable and makes sense. And what we would recommend is that we create this sort of audit style, and that we have a cycle of complaints that we look at. Maybe it's every other month, maybe, I think that's up for discussion of how often we do that, but that we pick set times a year that we look at certain complaints, that we pool those complaints in an audit style, that they're randomly pooled, and that the committee follows a template as they're reviewing those audited files, and then the committee shares back to the full board what they're finding, and then provides feedback to both the staff and the secretary and supervising member about what they're thinking about those closed complaints. It seems like a pretty, I think, good way to provide a feedback loop to staff specifically, and I think it could also provide some feedback to the secretary and supervising member. So we would recommend adding this in.
Is there a discussion? Stephanie, would you clarify for the Quality Assurance Committee, you're thinking the cases that'll be presented to committee members will be de-identified?
I would probably defer to Kim on this. I don't know that we've gone into that level of discussion. I don't know that they need to be identified. I don't know what value you would have in having them identified. I think they're, if we're asking, for the sake of why are we doing this, we would be doing this so that we could ensure that our process it's like any other audit. You want to make sure that your process is right along the way. Obviously, if there's something significant noted, I think that we would have to look at that on an individual basis, but it's really along, in the spirit of providing that feedback loop to staff and the secretary and supervising member. And to reassure the public that cases and complaints are being closed appropriately, that they've been audited and that that closure process is appropriate.
Well, I think it'll be reassuring to board members too, honestly. Any other discussion?
I would say, just jumping in, from like a structural viewpoint, I would like to see this fully discussed by the committee. Like how I think, what types of things we have for the review. I think that's all something that needs to be discussed. And, whether it should be de-identified at the time it's discussed, I think all of that should be part of what the committee talks about as you make decisions.
Thank
Agreed.
you. Mr. Jacobin.
Yeah, just one clarifying question. So this committee would essentially do an audit of cases that were closed, right? Or whatever. And they'd use a template and go through it, right? Is that what we're talking about? My question is, does it make sense more so to have a third party do that and then report back to the assurance committee as opposed to us doing it ourselves from a timing standpoint, a labor standpoint, and perhaps an objectivity standpoint? Just a question. That doesn't mean you have to take their report, but at least it might be another view on it. I just feel like going through this with a template and checking the boxes, I'm not quite sure how effective that is. And I also question how much time gets put into the process, if it's going to be laborious.
Sure. I think that for the sake of time, I would say that would be a great question for us to put on the very first agenda that we have when we talk about going forward, whether or not we want to go forward with this and how we would scope that out. I think that's a fair question. Is it an in-house process or is it an external process? And we can also look, as we're putting this stuff together, we can also look to see what some other boards are doing, both healthcare boards here in our state, as well as we can get FSMB said, they're happy to help us work through some of these recommendations with our peers and what they're doing.
And again, remember, we had this committee years ago.
We did.
We've had a quality assurance committee, and not exactly sure what happened to it, why it ended, but we have done this.
Yeah, I don't remember its existence, Michael. Maybe Mark does. Do you remember this quality? Do you remember it? I don't remember it.
I don't.
Okay, so that predates.
I think it predates me.
Anita told me about it.
Anita, okay, so we're really talking about it.
And maybe it goes through a war.
Anita told me about it years ago, several years
The Quality Assurance Committee existed in the late 1990s and a little bit into the early 2000s. And that's the last time we saw it. It probably has not met until since I'd say 03, something like that.
Okay, thanks.
Dr. Sohn.
Yes, thank you. I think there's potential learning opportunities from a quality assurance committee, but does Benton or anyone else that has working knowledge of this know and understand why we got rid of it in the first place? Because that may help guide us in the future to avoid mistakes, especially if it was repetitive and not worthwhile and extra work for no reason. I think that would be good to know.
Yeah, this is Kim. I think the reason that it was sunsetted had to do with conflicts for board voting, and that there was a concern that it was invalidating, like board members that reviewed the information and then they would have to recuse when things came in front of them. But I think there's ways to look at it, and I think that's probably what this committee should do. to be mindful of those issues and be able to address them and how you structure it.
Yeah, thank you. That's helpful because then we can make sure we don't make the same mistakes again. And to Mr. Giacaloni's point, it might be worth vetting to see what opportunities are for some sort of independent review or something.
I wonder, do we have a conflict? I was going to say a conflict in terms of releasing that information to a third party. I don't know.
Yeah, I
Sorry,
think those
Mr.
are lots.
You'd have to work through that, either through a statute, through a contract, you'd have to somehow give yourself authority to do that.
What? You don't need authority to do quality assurance. You don't need authority, Kim, with all due respect. I don't need law to tell me how internal processes should be done to make sure we do it well. And I'm not sure. I would bet dollars to donuts that part of the reason, if not a large part of the reason that it was removed was time. You see that this board went from 2 meetings and to 1 meeting in the sense that we need to narrow our time and our time commitments. And I would bet that it was as much under the rubric efficiency than it was anything else, because I don't see where you would have a conflict if the case is closed. In some rare case, I suppose, the physician comes back and there may be, but I would bet it's an efficiency question, what was considered efficient. But I don't think you need a statutory change to do an internal. I just think checks and balances are really important in a large institution, particularly when we're talking about the physician's right to practice medicine and the public's right to be protected.
Great. So I do think we're over time here. I appreciate all of the thoughts, and I think we have what we need to go forward. I will just clarify. I do think maybe Kim was talking about law if we had to release that to an external party, but I think this is great, and it gives us a lot to work on to bring back to all of you. And continue vetting out those FSMB recommendations. I think we've been really clear from the outset. Some of the things in the report we just don't think will work from us. Some of the things I think we can really take advantage of to make ourselves better. And so thank you all. This has been very helpful. Next on our agenda, we actually have, again, you all did such a nice job with our segues. We have implicit bias training scheduled with the Department of Administrative Services. So I'm going to stop sharing my screen right now. And I would, Joel, would you like to do the introductions for our DAS partners here?
Sure. So today we have Jennifer Adair and Jordan Harder with us from DAS, and they're with a new area of DAS of diversity and inclusion. And so as maybe some of you are aware, they rolled out statewide required training for all state employees, obviously with this important topic. And they've kind of tailored this presentation today for our board and kind of how your roles impact decision-making and implicit bias. So I'll turn it over to Jennifer and Jordan.
I think it's actually just me today, but that's okay. Hope you don't mind. So hi, medical board. I think the last time I actually saw some of you was when I did the sexual harassment training a few years ago. So it is good to be with you again. And as Joel said, this is your kind of specialized implicit bias training, throwing in some things that are a little bit more relevant to you and your role as a member of the state medical board. And I hope that, you enjoy. I assume that this is not the first time you've heard this topic. Being in the medical profession, as well as I know there's a few lawyers on your board, those two professions have really kind of embraced this idea of implicit bias within its own practices. So I'm assuming that you have a little bit higher level than what I would say some of our maybe everyday state employees have. So we're going to talk a little bit about it a little bit at a higher level. So if you have any questions or any thing you want to chat about as I go through, feel free to interrupt me, because I would love to hear more about what you have to say to make this even more relevant to you.
Hi, Jen.
So
this is Jordan. I am here. I just didn't have my camera on right away.
Jordan is here.
Wanted to let you know.
Thanks. Okay, so here's our learning objectives for today. And one is just to go through some of the basic concepts and understanding, making sure that you, just as well as the rest of the state, we have the same kind of vocabulary and understanding of what implicit bias is. And then really the second and really more meaningful, I think, to you at this moment is really to talk more about it as systemic bias and how it impacts you as a professional on the medical board, especially in your decision making. So we're going to watch some videos around that. So let's talk about some key concepts. First, defining this word diversity. So when you see this word, you immediately get some kind of emotional reaction to it, whether or not you knew that you did or not. And a lot of times people feel very negative about this word. I think even now in what's going on today, if you hear, someone says, you're going to go to, well, sometimes go, oh, right. And it is because it does feel very negative. People make a lot of assumptions about this word, puts people in boxes, separates people. It's what I like to call EEO diversity, right? So the counting of people, the labeling of people. But really what we're talking about when we are talking about diverse inclusion here for the state of Ohio is really this idea of appreciating and valuing those pieces of variety that people come in. So talking about it not as difference, but as variety. We actually have a brand new state competency for our staff to work on their performance evaluations around diversity and inclusion. And the second definition, human variety of experiences, identities, and perspectives that our employees bring to state employment, is how we define it there. So for our managers, they can use that when using that competency. We also like to talk about diversity on this wheel of different dimensions. And a lot of times when you hear diversity, your mind immediately goes to a few things. And again, it's triggering back to that EEO kind of boxes, but I'm sure you thought of race and then maybe quickly gender are two areas of diversity that we like to talk about a lot. But the truth is, those are just two of the many pieces of variety that we all come in as human beings. And so really when we talk about the concept of diversity, we are really talking about all sorts of things, such as your personality, right? You are uniquely you are your own variety. Then there's an internal ring. And a lot of the internal ring is where our EEO kind of pockets live. And you'll see as these pop up, things like race, gender, sexual orientation, ethnicity, ability, age. Those are the kind of the ring that society either assigns us labels or they're labels that we cannot really change about ourselves. And this ring is important, and we'll talk about this a little bit more when we get into defining implicit bias. But this is really, when you see someone for the first time, this ring is what triggers a lot of the implicit bias that kind of stems in your mind. The next ring is the external ring of our dimension. And this one I would even say is far more important in defining who we actually are as people than the green ring. And these are things that you have more choice over, more control over, things like your appearance, what you put on, where you live, things like your economic status, family status, education. Those all provide different layers and lenses of experience that you have, and that starts to shape the variety that you come in. Your religion or personal habits, your work experience, right? Your profession, that definitely puts a different lens over the way that you view the world. And all of these are very important pieces of who we come as in a variety. And the last ring, the ring we have to talk about in the work environment, is our organizational dimension. So we know that, our exact field of expertise, what division or department we work in, if we are a board member versus staff member, all of those things lead to a dimension of diversity. And so this is how it works in this organizational ring. So if someone says, oh, you're on a board for the state, and you say, yeah, the medical board, they immediately have ideas and thoughts that come into their mind about what that is, even without you saying anything. You say that I'm on the medical board. And if you talk to another board or commission, right? So maybe you talk to someone from the nursing board, you might have some stereotypes or ideas that, just based on saying what board you're on, you might have. So this outer ring is really important, especially when we talk about how we work together and when we start talking about systemic bias. So again, it isn't just about race or gender, right? We are really all of these things. And all of these things are very valuable when we talk about a full-scale diversity definition for the state of Ohio. Now, this word inclusion should feel so much better to you. And this idea of inclusion is really about bringing people together. And we as humans, we love that. We like to be part of something. And if you look it up, it's the act of including. And we talk about it in an organization, it's really about how are we bringing all of that variety that our employees, that our people come in, and how are we using that to really strategically move our organizations forward? Again, the second definition comes from that competency, the brand new competency, the practice of understanding and applying diversity to improve work culture and influence the way we serve Ohio. So again, tying our employees directly to how we serve. How do we include them in our strategic mission? So just as a side note, your agency, the process of a new strategic diversity, equity, and inclusion plan. And so I'm not sure how they're going to incorporate you, but just know that that's happening. And we're going to be taking a fresh next 3 years about what we want to do as organizations to kind of work through equity here in the state of Ohio. So we use this little picture math problem all the time. So here is just another way of explaining it. So here's you or your staff or your team, and here's the organization. And really the goal of a diversity, equity, and inclusion program in the organizational sense is to provide work cultures where people feel valued for who they are and what they bring to the organization. And in turn, the organization can utilize that diversity to improve strategic mission. Now, part of your strategic mission is to make sure that we have appropriate medical regulations. Your staff can bring their diversity, you can bring your diversity to really create more innovation around how you go about doing that. I think that's what your retreat is about, right? It's kind of talking through processes and practices and ways to really seek improvement. And we know that helps us improve our public service. And for you, that is to protect and enhance the health and safety of the medical profession for Ohioans. And so really this whole idea is that we're strategically using our diversity, we're including it in our strategic missions to create innovation to serve better. And so those are the big concepts of diversity and inclusion in state government. And we like to level set, especially around that idea of what is diversity before we do implicit bias, because we actually have implicit bias around all of those different dimensions of diversity. And so it isn't just about race. I know race is obviously the hot topic right now, but we can have it around all of the dimensions. So let's jump in to implicit bias. And we're going to start off with some brain games because as some of you know, implicit bias is a brain science and it lives deep, deep, deep in your brain. And it is just part of the way our brain functions. So we're going to start off with kind of showing you how your brain works. So we're going to play a series of games, and some, I will be honest with you, work better in person, but we are going to try anyway. And we'll play a series of games, and you can just kind of follow along, kind of play along as we go through. But this is all designed to show you how your brain works. So the first game we're going to play is a fill in the blank. So What I want you to do is, as fast as you can, I just want you to fill in the blank with whatever word comes to your mind, okay? There's no right or wrong answers. And if you want to, you can unmute yourself. Hopefully this doesn't cause a bunch of feedback. We'll see. You can unmute yourself and say it as fast as you can. That way we can kind of hear what's going on. If you want, you can write in the chat, but it works better if you say it. So I'm going to go ahead and flip the screen. And if you want to just say the first word that comes to you, we'll kind of see where we are. You guys ready? Okay, let's try it. Here is your first word. You're just going to fill in the blank with whatever word comes to you. Love.
Married.
Okay, let's try the next one. There's going to be another one coming right after. So the next word is day.
Night.
Okay, good. I'm hearing night. All right, let's try another one. High.
Low.
Low.
Low. Okay, let's try the next one. Cat.
Dog.
Dog. Okay. So I don't think I heard anybody differing on that was doing it verbally. So I heard love and hate, high and low, cat and dog, and I forget the other one. But what did we just do? What did we just do? You all kind of said the same words. How is that possible? Joel, did you share my slides with them before? Are they cheating?
No cheating.
You're not cheating. Joel's like, I didn't, I promise. You went to opposites as your first inclination, right? Your brain just told you to fill in the blank with an opposite. Why did that happen? Why do you think that happened? Anyone want to shout out why you think that your brain picked opposites as the first thing? Why do you think that happened? Well, I'll tell you why. Because as children, and if you think about if you've worked with children, we do a lot of associations with children when we're teaching them, right? And so a lot of it is there are opposites, right? You show the flashcards. On one side is the cat, one side is the dog, right? We do a lot of opposites in the way that we teach young children around association. So it was something that you pulled back, way back in your brain, right? Someone taught you these associations and it was pretty quick. You didn't really even have to think too hard about it. Now, you all started saying the same, not only the same words, but then you all started using the same convention of opposites. So as a group, you put yourself into group think. Have you heard that term before? Group think? So as soon as you got to probably through the second one, you just knew then that the rule of the group, whether it was totally unspoken, was that the answer was going to be an opposite. Now, even if you said to yourself, I think mouse, cat, mouse, you knew the group was going to say an opposite. So you probably chose not to participate. So instead of, saying it loud and proud, because I told you there was no wrong answer, you remain quiet because the group was already in a convention. And so this happens all the time. It happens all the times in meetings because groupthink really, it creates a space where difference is not felt to be appreciated. So we have to be careful as we get into situations where in large groups to kind of pull back and create space. And if we have a moderator or a chair, to always say, does someone have something different to add? Because this is where we need to embrace that great diversity and make sure we don't fall into it. So this is a little test to show you, one, how easy it was to do associations. You pull it back from your beginnings of learning, and how super easy it is to get into groupthink. Okay, here's the next one. I hope you all can read that. True or false? What do you think? True or false?
False.
Anyone else?
False.
False. Okay. All right. Let's do the next one. True or false? Can you read that one?
False.
False.
Right. So what would make this statement true?
Green.
It's false.
Were any of you, so I can't see all of your faces. Were any of you like, oh, how embarrassing. She forgot to spell check that slide. But guess what? I didn't need to spell check it because your brain went right ahead and you were able to read it. And so honestly, the true or false doesn't really matter. It's the fact that you could read it. And so our brains really, like to help us make sense of what doesn't make sense. In reality, most of these are not actual words, right? They're just letters that are rearranged. And so, but we know as people, as adults who can read English, that letters make words and words make sentences and sentences make paragraphs and they make concepts. And so anytime we are even scanning, when we see letters, our brain is trying to read them. And you may have seen this if you are on social media. I've seen this fly around that says, if you can read this, you're like among the smartest people in the world. Unfortunately, most people, if you can speak English, you can read English, you can do this. So your brain is just going to go ahead and rearrange those letters. And as long as the first and last are in the right place, it will help you. It's also why we can't spell check our own work, because we are moving too fast through it. So that's kind of a fun one to just show you how our brains just by themselves will go ahead and make sense of what doesn't make sense and use those associative concepts to do it. Okay, here's another one. If you want to turn your, unmute yourself, this is another talking one. And you might have played this one before. And you can, if you know what is going to happen, try really hard then to focus and see if you can do it better. So you're going to say the colors, like you're reading left to right, and it's going to be rows of color, and just keep saying the colors that you see. Okay, so the colors that you see, and I'll just tell you the colors are either red, green, or blue. Okay, so as fast as you can, say the colors that you see. Okay, here we go.
Green, blue, green, blue, red, green, red.
Green.
Yeah, that was good. That was really easy, wasn't it? Okay, I think you know what's coming next. Let's try it again. Ready? Go.
Blue, green, red, blue, red, blue.
Red, blue.
Yeah. So that was a lot. I don't know who was talking first, but you did that much faster. Why did you do that much faster? What do you think?
Because you didn't have to identify the color.
Yeah, because the word and the color match. We just talked about how we read just automatically. All right, I really think you know what's going to happen next. Are you ready? Try this one. Go.
Green, red, blue, green, red, green, blue.
Red.
Oh, are you sure? So this one's tricky, right? Because your brain wants to read the words, and the directions were to say the color you see, right? So this is that tension between the fact that your brain wanted to go on automatic pilot with reading the words, and your brain then having to tell you, wait, those weren't the instructions. And you had to say the color that you see. And a lot of times when we do this in person and it's a big group doing it, you can hear the point where people catch themselves. And there is kind of a, and then you go back and then it's a lot slower. You got to think it through. Give those to some of your friends and family. You can find them online. They're really kind of fun, little brain teasers. But again, this one shows you that difference between the automatic and that part of your brain where you have to kind of really stop and think. Okay, so we are going to watch, this is a video that has additional brain games. So we're going to take a look at that for a moment. I really hope, let me know if you can hear. I hope that the sound works. Can you guys hear it?
It's really quiet. It looks like it's turned down on YouTube, maybe.
Okay, let me see.
Still too quiet for me.
It's still too quiet.
Yeah, it was for me.
Hold on, let me try. I have like forced. Let's try this. Hopefully this won't blow your ears out. Okay.
It's quite blurry.
The picture's blurry?
Audio-wise, it's muddled. Can't really hear.
You can't hear it?
No.
No.
Okay, you know what? That's all right. I wasn't sure how this would work on this platform. I will just send this to you guys and you can watch it on your own. It is just a series of more brain games that are fun. And it goes through the same exercises that we just talked about. And, showing you how your brain jumps and makes different assumptions based on what you see. So I'll send you the link. No worries on that. Just another example. Let me get past it now. Next. Okay. All right. So why does this happen? All right. So I don't know if any of you know the book Thinking Fast and Slow, but it was referenced in the video. So Daniel Kahneman, who's a researcher, about the brain, he's put our brain into these two systems. System one is that 95% of the time of where we are. This is that very fast, unconscious, associative, or kind of our automatic pilot part of our brain. And we really like to be there. And it helps us survive as people, to be quite honest. And so we use this a lot. We use this a lot when interacting. We use this a lot when, we are making judgments. I don't know if any of you, I'm pretty sure all of you at one point have seen someone or been in a situation where all of a sudden you get that little funny feeling in your tummy where your tummy's saying, something isn't right here. Well, that is all of that 95% of your brain saying, something is triggering me and it's time to go, right? Now, we're only in system 2, 5% of our brain. So that is that very slow, methodical thinking. It takes us a lot of energy to be there. You guys are probably tired because you've been in it most of the day. And it takes a lot of effort. When you're in system 2, because your focus is so intense, you really kind of silo in and you can't see things around you. And it takes a lot of energy. And if you think about all of those really, critical decisions that we make around this rational thinking, it is you have to spend a lot of time and energy there. And so again, 95% of the time we are in our system 1 thinking. And why we stop and really say this is because system 1 is where our implicit bias lives. And if we're in it 95% of the time, we really think we're in control, but we're not. So our brain is just doing this all by itself 95% of the time. Okay, so what is implicit bias? And let me just tell you, all of our material that we talk about for implicit bias comes from the Ohio State University Kirwan Institute for the Study of Race and Ethnicity. They have fabulous resources, and they have lots of studies and research papers around all sorts of different equity issues around race specifically, and a lot even around healthcare. So if you haven't checked that website out or gone to them as a resource, that's a really great tool to have. And they're just, in our backyards here in Columbus, down the street, and they're really great to work with. All right, so what is implicit bias? Attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. So it lives in our 95% system 1, okay? And it takes those attitudes and stereotypes that you have, and it can impact the way that you interact with others, okay? And they live deep in your subconscious. You have no idea it's happening. But what happens is when you have those attitudes and stereotypes, they get associated with feelings. And those feelings are really what make you then react to things like people's race, ethnicity, age, or appearance, and you don't even know it's happening. And so you're using that, and it really can change the way that you interact with people, even though you don't want to. So here's some characteristics of implicit bias. Again, these come from the Kirwan Institute. The first thing to know is it's pervasive. Everybody has them. Everybody has it. I have it. Jordan has it. Susan has it. Everybody has it. Kim has it. Everyone has implicit bias, and we use it all the time. It's very distinct from explicit bias. So explicit bias is when you make a conscious choice, right? That you don't like something or someone, and you're working through that in your mind, and it's in the forefront of your mind. You know you're doing it. That is where explicit bias is, and those are things like racism, sexism, or just preferences that you state. Right? Doesn't have to go to that extreme. Very, very distinct. Implicit bias is all in your mind, in the back of your mind, in the subconscious. You don't even know it's happening, okay? It may not align to your declared beliefs or even who you are, one of your own dimensions. And this is because a lot of times they generally favor the in-group. An in-group can be defined in a few ways. One way is the in-group of society. So society, American society, has a privilege and power hierarchy. And so society as a whole has decided there are certain groups that are in and some that are out. And in general, our biases favor the group that society has told us is the in-group. And that's for a whole bunch of reasons that we'll talk about in a second. Now, it could also favor a group that you're part of if you are a whole group and there is a few outsiders. So, for example, right now, you all are an in-group of the medical board, and I, Jordan, and myself are the out-group because we are from DAS. And when we got introduced, Joel said, from DAS. And so right then, you guys might have been like, oh, another DAS training. So, we have these kind of attitudes and stereotypes about what group, right? So they generally favor the in-group. Now, again, they might not align to who you are or your declared beliefs. So it is very possible that if you hold a characteristic of a group that is not generally the in-group, you will hold them against yourself. And again, it's all in the subconscious of your mind. This is not by choice. But the great thing is it can be gradually unlearned. And that's what we're working through right now as a state with our employees. We're kind of working through identifying it, figuring out how it impacts us as people, giving ourselves tools and more learning, and then starting to talk about it more organizationally and how is it starting to impact our systems and the way we serve. And so it's a slow progression about really learning and kind of unfolding it to see how it makes its impact in our work. You might ask yourself, well, okay, that sounds interesting, but how did they get created in me? So if we all have them, I mean, what makes it happen? Well, you can start with the moment you were born, and implicit bias, because it's a brain science. It really has, it's part of what our survival instinct. So however you believe humans came on this earth, that is the moment it happened. And those early humans, or however you want to think about it, they had to have certain survival instincts, right? What was safe? Who was safe? All of this. And so these associations and all that started that. Now we don't need them to that extent now in life, but we still use it as part of the way we interact with one another. And again, that's that funny feeling in your tummy when you meet somebody new for the first time and you're just like, I don't know, maybe I should not be near them, right? And that happens to everyone. So it happened the moment you were born, and your grown-ups, whoever those people were, who brought you home or who raised you, who are around you at those very early ages, I'm talking like baby to 3, really started to influence your attitudes and stereotypes about people, places, things, experiences. And as you continue to grow up, so younger child, maybe elementary through middle school, things like the media. So what were you exposed to, in the form of media? So newspaper, radio, television, movies, all of that sort of, what messages are being filtered to you as a young child. Also education. What types of lessons were you taught? How were you taught? What were you exposed to in your curriculum? Those things start to shape your attitudes and stereotypes. And then culture. And culture itself is a very, very broad term. So not just ethnicity or race, but your town, where you grew up, what kind of, food, what kind of music, all of these things start to influence your attitudes and stereotypes. And as you then got even older through high school and maybe early 20s, your attitudes and stereotypes that were created as a young person become reinforced. So they start to get really embedded in you and become part of your identity as a person. So media, education, culture, those continue to reinforce, but also then your chosen profession. That begins to start to give you a different attitude and stereotype about people or experiences based on that. And then your network. And I don't know how many of you are on social media or have social media accounts on any platform. This right now is pretty, I would almost say a little dangerous, because we really control, especially in that social media world, who our friends are and who they are not. And as soon as someone says something we don't like, so that difference, it's so easy to unfriend, unfollow, unlike someone instead of being open and listening to why they might have a different perspective. So we really insulate our networks, and it becomes an echo chamber. And even now, in the way that media is consumed, we choose our media. Our media doesn't choose us, really. We go to the sources that we connect with, and not always, get the full idea or difference out there. So it really starts to solidify us in these attitudes and stereotypes. And then you become someone's grown up, whether you're a parent or an aunt or uncle, or you mentor kids, or there's a kid next door, or you interact with a child. You start to shape the attitudes and stereotypes that they start to have in their life. So it becomes full circle. And you're helping to create the way that they're going to start to perceive the world and how open they are to variety and difference. So this is kind of a picture of how it's created, which is kind of interesting. You can take the Harvard Implicit Association test. We'll talk about that at the very end. And we actually have some classes right now where we talk through some of those results that you get. And we spend a lot of time talking about these things, about how is that bias that I have, that I hold, how was that really created? And like doing a little self-reflection. It's kind of fun and interesting. So when does implicit bias come out? Well, we use it all the time, right? We use it all the time, but it comes out a lot in times where we are rushed, where we are stressed, when we are distracted, or we have extreme pressure. And it comes out in our decision-making in those particular circumstances. That doesn't sound like every day right now, right? Or when you sit and have to decide an enforcement case, or when you have to make a really tough decision about something, right? And so these are times where, under great stress, under great pressure, our brain wants to help us, and it wants to revert back to that 95%. Making those quick connections between things. And so it really wants to help us. So those are the times where we really have to make sure we're in system 2, where we're actually saying the color we see and not just reading the words, to make sure that we are, making sure we're focused on people as individuals and situations as individuals, instead of relying on attitudes and stereotypes. One thing that can also happen with implicit bias is this idea of creating a blind spot. So because we all have our own very unique layers, and all of our dimensions of diversity intersect at different ways, creating, the way we view the world, sometimes those exact things don't allow us to view it like someone else, because we don't get to pick up that lens and look through it all the time. And so our own implicit bias can create blind spots. So the ability where we forget or don't look through other people's lenses. So I'll give you an example. One of my personal blind spots, one that I work on all the time, is the blind spot of disability. So I am, fortunate that I'm an able person. I do not have any disabilities. And so it is not a lens that I look through. I have a child, but she is also able. In my family, there's no one with a disability. And so it's not something that I always look through, and I forget. And so even when I'm a presenter, right, doing diversity, equity, and inclusion, I forget to ask if anyone needs it in an accessible format, or, making sure that, it's compatible with screen readers, or, other things like that, because it's just something that I forget to do. It's not a lens I look through. So I have a blind spot, but I can work on it now that I have identified it. We all have these blind spots because none of us have every lens. And so this is something that, something we can work on as we kind of explore what our own implicit biases are and how they come together to form our unique perspective. Okay, are there any questions about implicit bias? So that's really it's at an individual level, right? It's how our own brains work, how we're processing information. We're going to move on now to a little bit of a bigger concept of systemic bias, which is how we work kind of in the organization and how our organizations work together. I can't see all of you, so if you do have a question, I'm sure the chat box works. You can stop me anytime, but we'll just keep going. All right, so we'll move on to systemic bias. So you probably heard this term a lot recently. It is another one of those kind of hot terms. So let's make sure we all know what we're talking about as we do talk about it. So we just spent a lot of time on implicit bias, which again is that individual level. There's also a term, institutional bias. So you've probably heard that too. And think about that as kind of implicit bias, but for an organization. So for example, the medical board in itself, in its policies and procedures, both formal and informal, has these tendencies and practices and procedures that might actually be causing a disadvantage to certain groups or favoring certain groups. And for the most part, it may be unintentionally written there or practiced in that way. And it's just a lot of times because it's just the way we've always done it, right? And so it's not something that was set out to do, but just kind of in the way that. So even though I said that sometimes it isn't intentional, we've evolved as societies, right, in terms of this idea of what is equitable or what is just. And so sometimes policies, looked at under today's lens, we would determine are not equitable. Most of those we have gotten out of our systems as we kind of have done updates to rules and to law. But sometimes those practices informally live within an organization. And so that's a concept of it at an institutional level. That's actually something we're going to be working with our agencies on over the next 3 years. We're going to have a little bit more focus on institutional bias, digging into policies and kind of examining. Now, another concept is systemic bias. So this is how our government systems kind of work together. So not just the individual organization, but the structure of the system. And so when all of us work together in government, for example, we're in the government system, and we all have the ability together to serve the public and provide for the general welfare of the public. Each of us in government have our own mission about how we do that. And sometimes our institutional missions overlap to really impact a system. So for example, obviously, you are in the health system. So you have a role in the health system, but so do a lot of other agencies, right? A lot of other agencies are impacting health. So, part of it is, do we have these systems in place that are causing greater oppression? Now, you, as the medical profession, you know this because this is something that has been studied. You guys are a leader in this when you are talking about healthcare outcomes and disparity. And so this should be nothing new, this idea of systemic bias and the way that these things kind of interact. Okay, So you are part of the healthcare system. And this is an example from the Kirwan Institute. I found a research paper there that talks about the healthcare disparities and kind of where we see the healthcare factors and what's causing those. And you can tell that it is more than just, is the medical provider doing what they're supposed to do, right? We know that outcome also is part of, environment or access. So it's a much, much, much bigger system, but we all have a very important role to play in it, but we also need cross collaboration if we really want to impact the system. So you guys know this, I'm so sure you know this about disparities and inequities, but I just wanted to put it up there as that example. So you are in the healthcare system, right? And I already told you that you have an impact and you know this through your mission. I'm going to ask you though, what is the thing you directly impact in this system? So I said, regulating, but how do you regulate as a board? What is the thing that you do as a board that has the most impact to the system? What do you think?
Probably regulating healthcare.
Yeah, absolutely. So you're regulating the profession, and it's not just doctors, right? You regulate several members of this profession, not all of them, because there's other boards that do others, but you have a large part of the profession. So even thinking about the profession when you're regulating, right? How can your own implicit bias impact your impact to the system? So when you're sitting there enforcing and regulating the profession as part of your job as on the medical board, your own implicit bias, so back to that person level, how does that impact the system? How could that impact the system? What do you think?
Well, we could circle the wagons. We could favor our own profession as opposed to others.
Right. That's a good one. So each of you are, you may be from different specialties, different practice areas. Some of you are not doctors, but you might have a bias, right? And that kind of bias would probably be an affinity bias, right? Towards your own in-group. And so being able to say, I want to make sure, because all of you I know want to, and you go in with every intention to do it, to make sure that you are being absolutely fair and equal, just check yourself for a second and say, am I doing it? Pulling yourself back out, right? Into that system 2 type of thinking. So yeah, that's one way. So when you see people of the same profession or practice area, what could be another one?
Well, race could certainly be another one. You could have a African-American person, hypothetically speaking, complete a $800 fraud and have their license revoked. And hypothetically speaking, a month later, you could have a white person complete a $600,000 fraud and get no further action.
Mm-hmm. And so that sort of thing, it has been well studied, obviously, in the criminal justice system. I don't know if any of you are from, well, I know some of you are from Central Ohio. There's actually a local school district that had this same issue. They disciplined 2 teachers for very similar things, and disproportionate discipline was given out, with the African American getting a harsher punishment. But that's an absolute thing that's been studied. And so, right, so checking and making sure that, we are being consistent in our decision making and the outcomes. That's a very good one. So definitely race, but also gender can do the same thing. What about, what's another one? I'm not going to help you. One more. So we got for different levels of profession and race and ethnicity, especially around outcomes and decision making on discipline. What could be another one? What about where maybe someone is from or where they practice? Could that be something that could enter your mind? Like someone that works for a big hospital versus a more, solo type of a practice? Could that be something? I guess what I'm trying to push you is into those different layers of the wheel or the dimensions of diversity, right? So all of those kind of things could impact. And it's just about catching yourselves. And some of you may have no impact to that at all. And some of you may really, trigger on it. People's accents, you hear someone start to talk, you're going to automatically start having assumptions. So, if you hear someone with a Southern accent, you might have different implicit bias that comes to you than if you heard someone talk with, say, a Boston accent or what you may consider a foreign accent, right? What about where someone, in reviewing their, their information, looking at licensure, and you go and you find in that information tells you where they got their degree and their degree from. Could that impact you? What if someone graduated from Harvard versus, or even a doctor from out of the country who has come, into the country and is now practicing? So thinking kind of through it more than just at the level of that one ring is where I'm really trying to get you to go to. But I think that you guys are right on about, it's really about your decision making, obviously. So when you sit there and you listen to cases and you listen to, people tell their stories, you're making all of these judgments and you are, trying to come to the best resolution. You're trying to find what I call, we do investigations too, the true facts of what happened. In all of that, you're using your implicit bias. You're using that ability to make assumptions and associations to really drive your decision. So, trying to pull yourself out of that is something that can really help you in that moment. Now, I did kind of pop in on your little discussion before because I came in a few minutes early to make sure I was on time. And I don't know much about your quality assurance, but kind of that idea that you were just talking about a second ago about checking in on your decisions, making sure they're equitable. That could be something too, if you want to look at it as a system, to ensure that, we don't have any of that institutional bias happening. So that would be one of those examples of where institutional bias could live that's impacted by your own personal implicit bias. So, so this is another video, but it seems that videos will not work today. So this one actually is a little bit longer. I will send it to you as well. It really just kind of highlights what we talked about in the area of decision making. It's from the American Bar Association, and it's designed for lawyers, but it's involving judges. Some of you may have seen it, especially the lawyers in the group. You may have already seen this video, but it's basically judges telling their stories about, finding out what their implicit bias was and how it impacted them, and then kind of reviewing how they were looking at cases and, being surprised, but, gaining some growth through that. So I'll make sure that you have that link. And if you just have a moment to take a look at it, it really just emphasizes, that one, implicit bias is in everyone. Two, it creeps out all the time, whether we like it or not. And it impacts people who are supposed to be impartial and even say, I want to be impartial. It's really hard to be impartial when our brain is just off doing its 95% of our assumptions and attitudes and stereotypes. So I'll make sure you have that video. But good news is that just means I finish up a little early. So I'll get you guys back on time since we started a little late. All right. Okay, so we actually don't have a your turn because you didn't get to watch the video because it's not working. But, maybe you can share some thoughts and ideas about, things that you might want to work on or resources as a board that you might want to work on, especially around this idea of, your enforcement responsibilities. I don't know if any of you have taken any of the Harvard Implicit Association tests. I would recommend that as something that you do. They have them for all different categories. It's a research study that's done from Harvard and a couple other universities. They use the data, but it can really help you kind of start to identify and work on where you are. And part of this is that personal learning experience about where you have your own biases. So I don't know if any of you have taken any of that, or if you have any reflections about maybe additional resources that you might need. Since our videos weren't working, my actual question on the screen doesn't really work for you right now. But I want to make sure that, we leave you with some tools and things that, really can benefit you in your work. And I'm sure your staff can chime in as well if they have something that they think might be helpful, that we can continue to help you learn and grow in this area if you haven't. Have any of you taken the Harvard Implicit Association test before? No? Okay. I'll make sure you have those links too when I send you the links to the videos. And those would be really good learning, starts for you. Okay, so I just want to leave you again to remind you about this wheel, because we do, especially again right now, our world is very much focused on a few of these, but in truth, we as individuals have so much variety. And when we are working with each other, when we are doing our jobs, enforcing the medical regulations, we actually are using all of these in our implicit bias. The way that we view people, the way that we judge people, the way that we are associating our past experiences to, decide truth or not. And so we use all of these dimensions all of the time, and each one is just as valuable as the others. So here's a couple things you can do to build your own DEI confidence. One, take the test. So I've said it a few times. I'll make sure you have the link. The tests are they're interesting. They range from various topics from, what we call the harder questions of like race to even body size. There's one even about presidents on there right now. They change them up depending on what they're researching. So go ahead and go to Harvard. It's a Project Implicit, and try a test and see what your results are. Gain more knowledge. I know that, again, the medical profession itself it's built in to a lot of the way that patients are treated around cultural competency. So I know that you as a profession are ahead of a lot of others. So you probably have better resources than I could in your own professional networks. So think about utilizing those to gain some more knowledge around cultural competency, and other types of diversity, equity, and inclusion topics. You're also more than welcome to come to any class. I know that it's sometimes tricky for you, but that's always open. We provide training on all sorts of different topics to all state employees, and I know we come and do this for you live, as a service to you, so you don't have to figure out how to log into Ohio Learn. But if you want to, you do have that access. Check your gut. So when you are up there and you are listening to cases, you're hearing cases, just pull yourself out into system 2 as much as you can, thinking of as the person as an individual, making sure that you are, judging solely on what you are hearing and seeing, not on your own associations or assumptions. Explore the system impact. So keep having conversations about, quality assurance and making our systems better, and then throw a little equity lens on that too. And it can be both your outcome systems, so like your enforcement, but also your internal systems too. I know that we've helped you do some work around your work culture, and so those kind of systems as well. And then apply what you've learned. So, take the time to learn, explore, and then try to work on it every day. This has been in us since the moment we were born. And for some of us, this is now the part of life where we are starting to learn and try to explore it. And so we're all new to this. So just appreciate the journey that you're on and take your steps as they feel comfortable for you. And keep practicing and keep being curious and keep asking questions. Find those answers. And that will help you in your own learning, but it will also help your institution, the medical board, as well as the system that you are impacting. So because we didn't watch the videos, I'm so sorry about that. I'm done now. So I guess that's good. We got done a little early and saved you guys some time since we started a little late. So I do apologize for those videos not being able to, the sound not working, but I will get you the links for those. And if you have any questions, I'm happy to take questions. You can also reach out. You can, reach out to your staff and we can provide you resources offline, or if you need something else, we are just here for you. I did want to mention that I'm not sure if you know this, some of the cabinet agencies signed on to the Ohio Executive Responsive Plan of Action to Advance Equity. It's something that the governor's office put out. I don't know if you have seen this. The premise is actually based off of the Minority Health Commission, their report around them looking at the disparity because of COVID, but it really expanded when they issued their report. It really expanded to more of a statewide government kind of look in addition to health disparity. So I just point that out because it might be of interest to you in your work, and it is something that is driving our next cycle of 3-year plans because the governor is interested in it. So I just wanted to highlight that for you as well. Okay, do you have any questions? Anything you want me to go back to talk about? Anything you would like to share? Okay, well, I really appreciate you spending some time with us. Again, I apologize for those videos. I will send links to Joel so that you can view those on your own. And if you do watch them and have questions, you can reach out. Thank you so much. And I guess I'll turn it back to Joel.
Yeah. Actually, I'll take over from here. I think that, medical board members, that really provides us a wrap up to our day. Jennifer and Jordan, thanks so much for being here. I think we have some things that we can continue to discuss as a board and can maintain that focus on the implicit bias as we go forward. I think Dr. Swain provided a good hypothetical for us to think through. Dr. Swain, do you have a question?
I do. I know she mentioned that this training will be happening at multiple state agencies. Can you tell me, is the Attorney General's office going to get this training as well?
So the Attorney General's, this training went out statewide. It was an electronic version for employees. I do not know if the Attorney General's office selected to do the training. But we are actually now working with the Attorney General's office and providing them some resources. So I do not know if they've taken our training or another implicit bias training. I actually started at the Attorney General's office in all of this, so I do know some of the employees have had this, but that was several years ago, so they haven't had the updated version.
Thanks, Jen. Okay. Great. Well, with that, we are grateful for your time today, and we'll continue to stay in dialogue with you as we continue. Dr. Schottenstein, I think we're ready to adjourn.
Oh, okay. Do we need a motion?
Yes, please.
I'll just have a motion to adjourn, please.
So moved.
So moved.
And Dr. Saffron, thank you. All in favor? Aye.
Aye.
Aye.